you ready? I can do a run through if you want it.
I can hear you clearly. We're ready.
Okay. Okay, so we're gonna talk about renal today. You have lots of handouts, but only one renal handout. So if you pull that out now, it looks like this. And I want you to kind of notice what's on the board. So we're talking about the RAAS system, and of course we go kind of fast, right? So you have to flow with your girl. We're talking about the RAAS, transurethral resection of the prostate, rhabdomyolysis, testicular torsion. All of these things will be covered relatively quickly in a way that should help you pass and succeed, okay? Now, so if you look at the front page, I want you to use this page, the front page, as a page that gives you an idea of what the kidneys do. Now, this is obviously an interactive program, so you're going to holler out, what do the kidneys do? And you gotta have 8 things. So what do they do? Filter, put that down, put excrete and filter. That's number 1. What else do they do? Chop, chop. Waste products, that's excrete and filter, right? What do they do? I can't hear you.
They metabolize vitamin D.
Okay, they metabolize vitamin D. That's number 2. Shout out another one. What you got, Rhonda? What do kidneys do? Sometimes it's a real simple answer. What do kidneys do? Yeah, make urine. Don't underestimate making urine. I've had 2 students with kidney transplants. One student got a kidney from her sister. When she came out of the operating room, having gotten this kidney from her sister, there was no urine. She bawled her eyes out. She didn't even get the effect of her sister's kidney. It didn't work. It didn't take. The next kidney she got was from a cadaver, a dead person. Thank God for that person. She's a nurse because of that person. When she came out of the operating room this time after a cadaver kidney transplant, she broke down and cried tears of joy because her entire Foley bag was full. Making urine is huge, okay? So you got number 3. What else are we doing with our kidneys?
They help in electrolyte balance.
Electrolyte balance. You already know the only way to get rid of potassium is to pee it out. If you can't pee, you have a high K, now you got a heart problem, right? Okay, because K is all about the heart. Okay, so we have a good 4 things so far. What else are we gonna do, Katie? What do kidneys do? What we got with the kidneys? They maintain what balance? Fluids. Fluids. So when a person goes into shock, what does everybody know happens? What drops?
Blood pressure.
Blood pressure, right? So the body responds to that by making you retain fluid. It makes the kidneys retain fluid. So the kidneys play a role in fluid balance, correct? So how many we got so far, y'all?
5.
Okay, we need some more. What you got, Harjot? What do Harjot, what they got? What do kidneys do? Blood pressure maintenance. I just told you that. Remember what you learned. Blood pressure is controlled by volume. Volume controls your blood pressure. Too much volume, blood pressure goes up. Too little volume, blood pressure goes down. So the kidneys maintain that fluid balance. Here's a hard one. Erythropoietin. The kidneys make erythropoietin. So as you know, when it comes to kidney function, anybody with kidney failure is going to be anemic, correct? Because erythropoietin stimulates the bone marrow to make red blood cells. So those are some things you got to know. Okay, what else do kidneys do? You got electrolytes, you got fluid balance, you got your vitamin D, you have your erythropoietin, you have make urine, you have excrete, you have your, we said electrolytes, right? What else do they do? Anything else? We got 8 things. Say what, sweetie? Uric acid is Good. So I want you to think, in this case, removes waste. Somebody said that earlier. It kind of removes waste. Here's some waste products. BUN, creatinine, uric acid. So it doesn't just filter, but it removes waste. We got 8. Okay, we're good. All right, let's roll. If you turn in your packets, you should have a handout that looks like, at least I hope you do. Looks like this, renal compensation. Somebody got that? On the back?
Yeah.
Okay. All right, cool. This is the hardest page in the packet. It's a lot of pathophysiology. I'm gonna go kind of fast, but you will understand it. Rewind and fast forward, okay? So if you look at RAAS, what does the R mean, everyone? Renal. What does the A mean? Angiotensin. And what does the other A mean? Okay, aldosterone system or syndrome. Renal. When a patient is in shock, and what I want you to do on the top of that page is I want you to put on there shock response. Because it says renal compensation and shock. You've got to remember this is what the body does to save your life. Hopefully you wrote out all those words, renin, angiotensin, aldosterone syndrome, okay? So you have got to make sure you know this is all in response to shock. This has nothing to do with kidney failure. Are you still with me? Okay, so it has everything to do with what happens when your body goes into shock. All right, now, so here we go. Everybody knows when you're in shock, doesn't matter what kind of shock, septic, hypovolemic, distributive, neurogenic, cardiogenic, it doesn't matter what kind of shock, all blood pressure is low. So we start off with that, right? So the low blood pressure stimulated your kidneys to produce renin. Renal, renin. Now, renin was in direct response to this blood pressure. When renin is produced, and it is a protein, it is going to stimulate the production of another chemical called angiotensin. When we get renin, renin is a punk. It doesn't do anything quite right. It gives you a little bit of vasoconstriction, but not enough. So it gives a little bit, but not enough. So what does vasoconstriction do? Raise your blood pressure, right? So if you give a little bit of vasoconstriction, you get a bump in your blood pressure, not enough, it's a punk, we need more help. Your blood pressure is super low with shock. That little bitty bump, that'll do shit. So we need to raise the blood pressure more, and we need something that is a stronger vasoconstrictor. So renin stimulates angiotensin production. So let's look at that word, huh? Half of the things on a test require you to look at the word. Angio means vessel or artery. Tensin, tension, does it mean vasoconstrictor? No. Vasoconstrict, it's putting tension on a vessel. Vasoconstrict, okay? So now angiotensin comes along and it's a much stronger vasoconstrictor. So what is our blood pressure doing? It's getting bumped up a little higher. It's not strong enough. Now we need angiotensin 2. So angiotensin 1 is converted to what? Where at? In the lungs. Uh-oh, pump your brakes. If angiotensin 1 is converted to angiotensin 2 in the lungs, then that explains why an ACE inhibitor, what does ACE inhibitor mean? Angiotensin converting enzyme inhibitor. That explains why the ACE inhibitor, which stops this conversion, where does the conversion happen? In the lungs. That explains why the ACE inhibitor gives you a cough. That explains it, because it's working in your lungs. So if the ACE inhibitor has to work in your lungs and stop A2, A1 from becoming A2, then what did it stop? It stopped vasoconstriction. If vasoconstriction raises blood pressure, stopping it essentially is vasodilation, it will lower it. Now we have a blood pressure medication. You better know what these meds do. So far so good? ACE inhibitor. Okay, so let's keep on moving because we're not trying to lower the blood pressure in this patient, we're trying to raise it. So let's keep on going. We have a conversion of A1, which was a stronger vasoconstricting agent than renin was, because renin was a punk, remember that story? Okay, now A1 is being converted to A2 in the lungs. Oh, A2 got it going on. A2's like, okay, for real, your blood pressure low? Oh no, we won't play it like that. We're really gonna get it high now. It almost like completely vasoconstricts. It's amazing for shock. Not so great for everybody else. For shock, it's cool. So we have now vasoconstricted in such a strong way, our blood pressure's looking better already, but it ain't good enough. So we're gonna keep on going. Now this you know. Angiotensin II stimulates the adrenals. What do I teach you about adrenals? Let me show you what I teach you about adrenals. When we do endocrine, if you look at the word, and I just told you half of what we do, you gotta look at the word. The adrenals mean additional renals, really, don't they? In a weird, sick way, because your kidneys control fluid and so does adrenals. Your kidneys control potassium and so does adrenals. Your kidneys control some thirst responses as it triggers a bunch of other stuff in osmolarity, so do your adrenals. Your kidneys control sodium, so do your adrenals. Your kidneys play a role in dehydration and fluid overload, and so do adrenals. Okay, so additional renals. And then to make it easier, where are they? Scully caps on top of your kidneys. They're just like little scully caps on top of your kidneys. That's where the adrenals are. They work together. So now we have angiotensin II stimulating the adrenals. When it stimulates the adrenals, you know the word adrenaline. Also aldosterone. So now we have the third letter in RAAS. Y'all cool? We have aldosterone. Now wait a minute, hold up. Aldosterone. Uh-oh. What that mean? What that sound like it means? It sounds like it means steroid. And this is why you do have to know the action of some of these drugs. Because if you know anything about steroids and you figure that this aldosterone looks a lot like steroid, then you know steroids make you retain sodium in water. In particular, this action, this stimulation of the adrenals producing aldosterone will make you retain sodium. That's important. Aldosterone makes you retain sodium. Sodium is married to who? Water. Water. So now you're retaining water as well. So far so good? What does water or volume do? You see the bump? Now we done had two things, vasoconstriction and sodium retention, which led to water retention. Now we really look like we got a better blood pressure. It makes sense. It just makes perfect sense. You gotta know this. Now, if we retain sodium, who's the opposite electrolyte from sodium? Uh-oh. So when we retain salt or sodium and sodium's high, who's low? Potassium. Oh, okay, that's kind of important. Because didn't you have a high potassium before? We're trying to get it down, right? Okay, now peep this. This is where you gotta know your meds. What medication stops that aldosterone? Aldactone. Oh, sounds a lot like it, doesn't it? Now peep this. What is aldactone? It's a type of what? Diuretic. Say it with your chest. Act like you fucking know this. So aldactone is a diuretic. But what you had to know about it, and it's all in your pink medication packet, is that when you give a patient aldactone, and the perfect patient to give aldactone is a liver patient, you actually retain potassium. Makes sense. If it stopped this, it stopped sodium and water retention. Now you're peeing, diuretic. Now you're getting rid of salt, sodium low. Who's high now? Aha, you gotta know it. So if I have a liver patient, liver disease, you know that I taught you alcoholics are at risk for alkalosis, where all K is low. So if the cirrhosis patient has a low K, then aldactone is a perfect drug because it's gonna hook their K right on up. Is it making sense? Know your drugs. Know what you're doing with your drugs, okay? All right now, so here we go back to that ACE inhibitor. Didn't we say that the ACE inhibitor stopped the conversion of A1 to A2? So if that happened, could the angiotensin stimulate the adrenals? If you, think about it, if you stopped A1 from becoming A2, could A2 stimulate the adrenals?
No.
No. So when you give an ACE inhibitor, you stopped A1 from becoming A2, so you stopped vasoconstriction. You stopped A2 from stimulating adrenals, so you stopped the production of aldosterone. And when you stop the production of aldosterone, you stop sodium retention and water. That's why ACE inhibitors work on preload and afterload, because they do both. Preload is volume, afterload is resistance or vasoconstriction. The ACE inhibitor works on both of those. That's a little cardiac for you, darling, for free. Okay, so here we go. Y'all got it? This is your RAAS system. Look at the handout. It says, thou shalt not pee. You ain't peeing, you keeping all your water on your body. Aldosterone equals sodium and fluid retention. Angiotensin 2, vasoconstriction, blood pressure high. You see it, it's all on there already. But here's what's on there that you may not understand. We still got one more thing, y'all. Peep this. We still got ADH. So how does that play a role? What does ADH stand for? You want to say it like you care?
Anti-diuretic.
Oh, okay. So anti-diuretic hormone. Am I peeing or not peeing with anti-diuretic hormone? Okay, so I'm not peeing. Y'all all right with that? Okay, now stay focused on this, because this is, again, one of the hardest pages in the packet. Everything else flies. You're in shock. Your blood pressure's low. I taught you the Jay-Z rhyme a long time ago. No BP, no PP. Now you kind of know why. Okay? So your blood pressure's low. You can't perfuse your kidneys. Even when you do, your kidneys are trying to save your water. So either way, you're not peeing. So far, so good. No BP, no PP. Okay? Now, we've got our blood pressure low. It has stimulated the production of renin. Renin has stimulated the production of angiotensin. Angiotensin is converted to angiotensin 2 in the lungs. Angiotensin 2 stimulated the adrenals. The adrenals put out aldosterone, as well as angiotensin 2 stimulated the pituitary, the posterior pituitary. When angiotensin 2 stimulated the posterior pituitary, it put out ADH. Now you gotta be careful. Please write this down. Antidiuretic hormone is produced in the hypothalamus and secreted by the posterior pituitary. So I'll say the PP. does the PP. Posterior pituitary, PP, does the PP, ADH. ADH is a PP hormone. In this situation, it's gonna make you not pee. PP for the PP. Y'all good? Okay, now watch this. Once angiotensin stimulates the pituitary, remember, somewhere way back in the day, it was already produced by the hypothalamus. Now it's going to be stimulated to secrete in the posterior pituitary. So it's kind of like liver and gallbladder. Remember that deal? Liver produced bile, gallbladder secreted it. Hypothalamus produces ADH, pituitary secretes it. Y'all cool? Okay, so angiotensin 2 stimulated the pituitary, posterior pituitary, to produce ADH. The ADH did a couple of things. The anti-diuretic hormone made sure you couldn't pee. It made sure you couldn't pee, but then also it increased your thirst. So you would drink more water. It stimulates your thirst. Okay, so you get thirsty, you drink more water, your blood pressure will go up. See how that all works? Okay, now, here's our little deal. ADH also responds to, osmolarity. Osmolarity, O-S-M, right? Normal should be what? Less than 300, okay? Okay, osmolarity, let's rewind the tape in your mind, because I teach you this all the time. Osmolarity is the thickness of the blood. We gotta do fancy, remember we do fancy on some of these words. $4 word. Thickness of the blood, ain't gonna say thickness on the blood on no test. What's the word?
Viscosity.
Viscosity. $4 word right here, viscosity. So the thickness of the blood is how viscous and concentrated is your blood, viscosity. That's the definition of osmolarity. How concentrated, thick, or viscous is the blood. So when your blood is really thick, ADH is going to be produced. Because if I can get you to drink more water and hold on to more water, I can dilute this blood. Makes sense? Now wait a minute now, hold on. What if you have brain surgery and you damaged your pituitary and you can't secrete any more ADH? Remember you said when I got ADH, I wasn't peeing. Now I've had damage to my brain from surgery maybe, and I can't produce any more, I can't secrete any more ADH. Now what am I doing? Peeing a lot, polyuria, DI, that was endocrine. All of these systems tie in together. It's just you were taught real dumb stuff one at a time. You gotta tie them all in together or it ain't gonna make sense. ADH is endocrine, but it's also renal, because endocrine, adrenals, is additional renals. Is it making sense? Okay, now we can actually move on fast. Okay, so that was your RAAS system. When we go to the next page, you should have something that says acute kidney injury. So good, so far so good? Okay, let's just get this out the way. Rightful, acute kidney injury, whatever the hell you want to call it. Make sure you know that this used to be called acute renal failure, right y'all? It's acute kidney injury. You want to use the right terminology. There are 3 times. Write it at the top, like I did. There is a pre-renal, there is an intrarenal, and there is a post-renal. Write that at the top. Okay. Now, so when we look at pre-renal, I use a couple tricks, right? Pre-renal perfusion. That's how I want you to think. Pre, P-R-E, per, P-E-R. Switch the letters around, be all right. Okay, so pre-renal is perfusion issues. So what has to happen for pre-renal kidney injury? Your blood pressure had to go way down real fast, because what did we say BP was? Blood perfusing kidneys. Boom. So what makes your blood pressure drop super fast? Shock or trauma, because you did what in trauma? Hemorrhage. Boom. Hemorrhaging. Trauma from, and then related hemorrhaging, shock, right? That's what it is. Shock and hemorrhaging will cause pre-renal kidney failure. Acute kidney injury, okay? Pre-renal. Now, if you ain't got no BP, you ain't got no PP. So what goes with this? Oliguria. Okay? So far, so good? All right, let's keep it moving. The next one is intrarenal. And again, we got tricks. So if you think of intrarenal, we're gonna say injury. Keep the eyes together. Intrarenal injury, right? I, just like PP earlier, okay? Intrarenal injury. What injures kidneys, everybody? Think, what could cause them to shut down because it injured them? No.
Medication.
Which ones? Aminoglycosides, give me some more. NSAIDs, give me some more. What else y'all think? We say you gotta check it before they can have it. What else? Contrast dyes. So listen, aminoglycosides, which is your vancomycin and your little myosin drugs, right? Vancomycin, gentamicin, tobramycin, streptomycin, boom, mycin. Okay, but don't get confused. Erythromycin ain't in that group, but vanco is, and you use a lot of it. So aminoglycosides are toxic to the ears and the kidneys. Nephrotoxic, ototoxic, boom. NSAIDs, Motrin, Aleve, Advil, ibuprofen, naproxen, Anaprox. I could go on and on. Feldine, I could go on and on with the hot mess. These are toxic to your kidneys. Patients with kidney failure got no business taking them. People out on the streets take a lot, and they put themselves right in kidney failure. Okay? So this is injuring the kidney. The structures of the kidney are being damaged. Okay, let's go a little deeper. PPIs, proton pump inhibitors. They have been associated now with kidney failure. So I have a really good friend. She's talking about she on that shit for 2 years for heartburn. Wrong answer. How long you should be on a PPI for some damn heartburn? 2 weeks. 2 weeks. You better know it. Got a little black box warning on there. You taking them longer than that, you should have seen a doctor by now. Now it's a whole other thing to take a PPI for a GI bleed. That is not what I'm talking about. I'm talking about this nonsense where you go to Sam's Club and get the big ass box full and you take shit every damn day with your heartburn cell instead of getting on a treadmill and losing weight, because obesity is associated with heartburn. Okay, think it through. Everything you take has damage. It has some side effects. Everything we take. Magnesium can damage your kidneys. Go out here and drink Maalox all day, every day. You're gonna damage your kidneys. Patients with kidney failure should not have Maalox. I got news flash for you. When you get out in the real world, they're gonna give you magnesium-based products. They're gonna write it on every single patient in long-term care. All these doctors, milk a mag. You come along, and if you're stuck on stupid and parked on dumb, when the patient talking about they constipated, here, baby, take this milk a mag. You didn't even notice that they had kidney failure written at the top of the chart. No kidney failure patient should be taking any magnesium products. Milkamag, Mylanta, what's the other one? Maalox. Yep, don't do that. So those antacids, or whatever you want to call it, that ain't cool. Okay, so what we got so far? NSAIDs, aminoglycosides, PPIs, magnesium-based products, and contrast dyes. There's no reason why you, my love, prepared a patient with an IV and everything for contrast dye, and they have lupus or stage 3 kidney failure. The hell was you thinking? That's inappropriate. You should question that order. They can get a CAT scan, but they can't get that contrast dye. CAT scan with contrast, eliminate the contrast. What else will kill your kidneys if you're on what drug when you get the contrast dye? Metformin. You ain't supposed to have metformin 48 hours before or after. What the heck is going on here? No metformin 48 hours before or after contrast diets. You feeling me on this? Okay, so you know, it's crazy. This is stuff happens every day. That's why folks be going into problems, okay? Now, so you get it. This is acute kidney injury. Now, what I want you to write is that most acute kidney injury is related, most acute kidney injury was related to intrarenal. And this is what it's called. Acute tubular necrosis. In other words, beloved, acute tubular necrosis is injury to the kidney from this patient taking some of these drugs or maybe some chemicals, okay? That is what the fancy name is, acute tubular necrosis. It's gonna lead straight to acute kidney injury through the intrarenal process. So far, so good? Okay. Now, there's a big fancy word that will help you. Rhabdomyolysis. Rhabdomyolysis leads to intrarenal injury, which then is acute kidney injury. We talked about this in toe-to-toe. What medication could be too high and cause rhabdomyolysis? We said it in toe-to-toe. Nope. Y'all forgot just that fast. The dose could be so high. That's why you should come to toe-to-toe, because it's on your test. Rhonda, what is that medication where 80 milligrams, or if you put more than 80 milligrams, statins? How quickly you forgot. Statins, high doses of statins. And what are statins? Cholesterol medication. What's the other name for statins? Cynthia? What's the other name for them? I told y'all, let's see who was here. What's the other name for statins? I gave y'all some letters to remember. Sarah, what were those letters I told you in toe-to-toe? Katie? Nope. What were they? HMG-CoA. It's toe-to-toe, that's a lot. HMG-CoA are statins. Statins in high dosages can cause rhabdomyolysis. Excessive exercise and protein intake. That's your muscle man over at the gym. They cute and all, but they about to shut down their kidneys with that dumb shit they doing. Okay, all that exercising. Cause look what's going on, y'all. Keep this. What does myo mean? Muscle. What does lysis mean? Destruction. So you destroyed your muscle. Now I don't know what the hell rhabdo mean, but for your purposes, say to yourself renal. That's how we're gonna do it, y'all. I don't know what the hell rhabdo means. You find out, let me know, because I don't know. So what I'm saying to you is the word. You gotta look at the word on these tests. They tell you what they mean. Destruction of muscle causing renal failure. Working out too much or prolonged bed rest. See, watch this. If I take my arm and do nothing with it, because I'm on prolonged bed rest with spinal cord injury and I can't move it no matter what I do, unless your behind come around and help me. This muscle is going to atrophy. It's going to waste away. Because for a muscle to stay built up, you must contract and relax. Prolonged bed rest, prolonged relaxation will break down muscles. If you don't use it, you'll lose it. When it comes to contracted muscles, working out too much, or, you guys know this, neuroleptic malignant syndrome, or malignant hyperthermia, in which your muscles stay contracted and never relax, you're still gonna break down that muscle. So rhabdomyolysis is a complication of malignant hyperthermia, neuroleptic malignant syndrome, And of course, prolonged bed rest and excessive exercise. That's what it is. Okay, now, we have a patient that has acute kidney injury from rhabdomyolysis. What should we do first? What is the first nursing action? Ola, what do you want to do first? Exactly, hydrate. Don't make me wait that long. Hello, you got a tape to do. Hydrate. Hydration is the first nursing action for rhabdomyolysis. Okay, all right, you're doing the doggone thing. Now, we had one more. He had post-renal injury, post-renal failure, post-renal issues. Think about it. Post-renal means your blood pressure was fine. You actually perfused your kidneys. They actually made urine. Post-renal, they did all that. It happened post-renal. They functioned, they perfused, they made urine. Post-renal. O for obstruction. Now the urine can't get out. Post and OBS, obstruction. So now the urine can't get out. Now you said it earlier, what is it? What kind of example is this? When can the urine not get out? What did you say, Eddie?
Kidney stones.
Kidney stones. That's an example of post-renal obstruction. Kidney stones. Enlarged prostate. Cancer. What if there's a big old tumor in the way? Can't get out. Enlarged prostate. So far so good, y'all? All right. Okay, boom. Now, here's the deal. You have those three types of acute kidney injury. I need you to know with the first one, which was pre-renal, you have oliguria. With the second one, you actually still make urine. You don't have oliguria yet. You might get it later, but you don't have it yet. So no oliguria. Make sure you know that. The last one, you have something called anuria. A before word? Without any P at all. So far so good? Okay. Now look at the rifle. Look at the word rifle. Each one of these are stages of acute kidney injury. The R, the I, the F, all this crap, right? You got a few more things to write on this. Where it says R for risk, I want you to, when it says first stage, I want you to write down. Matter of fact, you ought to tell me. What's the first sign of kidney failure? What'd you say? T-color urine? No, that's glomerulonephritis. We did that toe-to-toe. What's the first sign of kidney failure? Acute kidney failure. It's a lab. Creatinine. That's what you better put first. First sign is increased creatinine. That will happen first. You must know that, everyone. First sign of kidney failure is an increased serum creatinine. Okay. Second sign, what can't come out if you can't pee? So under the second stage, now put high potassium, just like I did. Boom, high K. Only got one thing under each one. Y'all cool? Okay, now we got a third stage. Now I want you to put high BUN. Now we have a fourth stage, and that's where you have oliguria. Pay attention to the last one, the E. It says end-stage kidney disease. I need you to know, if you look at it, complete loss of kidney function for 3 months or more. Now we're in end stage. Because here's what you gotta write, you gotta write it real big. 99% of all AKI is reversible. You will recover. So most AKI is recoverable, right? It's reversible. You will recover. Your kidney function will return when we fix the problem. A very small percent will be so damaged that they can't recover, and then you slide into something called end-stage renal disease. We don't make that assessment unless it's been 3 months. If it's been 3 months, boom. You ain't made no pee, oh shoot, she got kidney damage for life. Now you need dialysis. Now, it takes a full year, write it down, takes a full year for your GFR to return to normal. What's GFR? Glomerular filtration rate. Okay, let's keep it pumping. Next page, quick. Now, the next page says acute kidney injury, signs and symptoms. You have 3 phases. Keep in mind, this is reversible. So this is not chronic kidney disease. This ain't Big Mama now. This is somebody else, okay? So if you look to the title, acute kidney injury, now it's talking about signs and symptoms. For the oliguric phase of acute kidney injury, be careful about what you learned in school. It wasn't wrong, it was just maybe a little incomplete. What did we all learn oliguria is in school? Less than what per hour? 30. Well, that is good, but it ain't great. So less than 30 cc's is true. Less than 30 cc's per hour is true. But I need you to know another number. Look at it. Less than 400 cc's in a day. Highlight it. If it's a little one, pediatrics, you can't forget the little ones, you're gonna have a different kind of calculation. And this is true for all kinds of things, pediatrics. For calculating what dosage is and all this stuff, we say for the baby, 1 cc per kilogram per hour. Make sure you know your pediatric issues. 1 cc per kilogram per hour. So if this is a baby, it's a little different, okay? Now let's look. I want you to highlight the word cast under that urinalysis, and remember that when you see cast on a urine, the kidneys have been injured. Usually kidney stones will do it. Okay, so cast. Everybody see it? Okay. What color is the urine if that specific gravity is what it says? What color is the urine? Is it dark or pale?
Dark.
You don't know your specific gravity, obviously. Specific gravity on this patient, if you look at it, is it low or high? It's low. Low specific gravity equals pale urine. This patient's urine is pale because there was no chronic issue. Right now, we're still pale. Know your specific gravity. You already know metabolic acidosis because what did you retain? Uric acid. Remember, you were supposed to excrete that waste. You did not. You can't pee that much, so you are maintaining or retaining uric acid. Uric what? Acid. What is that? Acidosis. It's not a respiratory issue, it's metabolic. Boom, highlight it. Okay? All right, now, hyperkalemia, but then something really weird. Hyponatremia. I promise you, you gotta know that. High K, low sodium, they're opposites anyway, we can roll with it. They're opposites. High K, low sodium, they are opposites. Okay? Now, if you look at the diuretic phase, when this patient starts to recover, we've got to get rid of all that water that they retained. When you get rid of all that water, when you keep peeing, what are you also going to make go down? There you go. This diuretic phase, I need you to put in really big letters, low K. But when you get rid of water, you're also getting rid of salt. So we have a low sodium. Now we're at a point where both of them are low. Because every time you get rid of water, water and salt are married. So the more you pee, the more sodium you lose. The more you pee, the more potassium you lose. Making sense, isn't it? Okay, so potassium and sodium are both low. What controls your blood pressure? You're getting rid of a lot of it. So what's your blood pressure? Highlighted, it's on there already. Now you're getting rid of your waste, your BUN and what? Creatinine. So they're lowering, they're getting better. Doesn't it make sense? Okay, now, let me tell you what I need you to write so you got a clue. I just told you about osmolarity. Now you are peeing. So you are doing something called, and the diabetic does it too, osmotic diuresis. Osmotic diuresis. Because would you agree that when you weren't peeing, you had a fluid volume overload? Now you're getting rid of the water. Diuresis, osmotic diuresis. All that water gotta come off. Osmotic diuresis, that's what that phase is, diuretic phase, osmotic diuresis. Now you go to the bottom, you're recovering. Just right, it takes up to a year. If it's been 3 months and your kidneys don't return, what do you have, everyone? End-stage renal failure. Next page, chop chop, let's go. Now, we did our no BP, no PP, we'll get rid of that. We did our AKI, I erased that, and we still got a little bit of love. Okay, now, it doesn't really matter if it's acute kidney injury, chronic kidney injury. Wouldn't you agree that once you grab a renal packet, the first thing that should have came to your mind was daily weights? Okay, so it doesn't matter which one of these they have, right? And we even say a little bit more about that. We say that any patient with any kind of organ failure should be on daily weights. Heart failure, kidney failure, liver failure, boom, daily weights. So far so good? Okay, so as we venture a little bit forward here in this lecture, we are now talking about who needs dialysis. Of course, acute kidney injury needs dialysis, but so does end-stage renal disease, right? So that would be your chronic. Now, this AEIOU stuff, I like it because essentially it's telling you what could damage the kidneys or what kind of people could get into trouble with some problems that require dialysis. You know acid-base problems require dialysis. What kind? Acidosis. Metabolic acidosis. And how could you possibly get into trouble with that? Well, you could have a situation where you are in DKA. You could have a situation where you are in AKI. So the acute kidney injury patient will definitely have some acidosis, okay? Now, when you look at electrolytes, there are patients who come in with their potassium so high, and so high is 5.8 or higher. So high that they just need dialysis because insulin and everything else ain't gonna do it fast enough. Okay, there are those patients that come in like that, 6s and everything else, about to die, right? You grab the EKG and everything because you knew this is bad. So those patients with that ridiculously extremely high potassium, of course, would require dialysis. But that's not the only patient that will require dialysis. Patients with any other electrolytes that are really high, magnesium, calcium, phosphorus, whatever. If it's really high, it's gotta come off, dialysis, okay? Now you look at intoxications. This is poisons and toxins. When you poison and give somebody something toxic, whether they overdosed on a bunch of medicines, or the kids drank antifreeze, or they swap, what is that? What is they doing? They stupid asses is doing pods, Tide pods and shit. When you're doing all that retarded stuff, you are shutting your body down. Poisons and toxins may require dialysis, okay? So you knew that. This is not like, kindergarten. Okay, now look at the overload of fluids. Lord knows that a fluid volume overload is a reason for dialysis. This is usually the patient who missed their dialysis appointments, correct? Now let's remind ourselves what's going on with this fluid volume overload. Since you doggone sure better know your select all and everything about it. So if I have a fluid volume excess or fluid volume overload or circulatory overload, boom, I am going to have classic hallmark symptoms. We do a methodological approach to how you figure this out. We teach you go from head to toe. So let's do it. What's going on all up in here? Headache. What's going on all up in here? JVD. Now remember, in the head department comes respiratory. What's happening with that? Shortness of breath. What about your respirations? Increased or decreased? Increased, because it's hard to breathe with a lot of water on your body. Y'all feel me? Okay, so far we got a little headache, we short of breath, we got increased respirations, we got JVD. That was all up and around in here. Let's walk the body. We in here now. Crackles, very nice, crackles. What we got going on right here?
Blood pressure.
High blood pressure. Doesn't volume control blood pressure? Now let's move on down this arm. What's the quality? Bounding, rapid pulse. That's called tachycardia. Bounding, rapid pulse. Anything all up and around in here? Ascites is possible even when it's extreme though, right? It's not gonna be typical. Make sure you know it's not typical to have ascites. But if you do, that's extreme. That's extreme. You'll see that with extreme heart failure, extreme liver failure, right? So if it's extreme heart failure, which kind of heart failure might give you ascites, right or left? Right. Mm-hmm. Okay, let's keep it moving. What we got going all up and around down up in here? I do. Mm-hmm. Now, we did daily weights. The patient had some issues. We did some daily weights. So included in your fluid volume overload is weight gain. Let's take this a step further, shall we? You did what blood work on this patient? What did we run on everybody, shit? CBC. Do we need a diff? No, there's no infection. We need a CBC. When we got a CBC, was the H&H high or low? Explain. Antonio, explain. Why is the H&H high? Explain. Janae, explain. Why is H&H high? I'm asking Janae.
Increased fluid cause volume increase.
H&H for this patient, is it high or low? Eddie.
It's gonna be low, but it's diluted.
Thank you. The H&H is actually dilute. You got so much water, your blood ain't even deep red no more. The H&H is actually lower. Be careful. Think it through. If I don't have any water in my body, my blood is thick. My H&H is high. You gotta know this. Suddenly your fluid volume overload patient is giving you pink, frothy sputum. What's wrong with them now? Pulmonary edema. Extreme, right? That's a late sign. Pink, frothy sputum, late sign, pulmonary edema. They could cause, all this fluid on the body could cause another organ to fail. If it's kidney failure, it can lead to what? Heart failure. Yes, say it with your chest. Don't whisper, little babies. Okay, y'all good? Y'all all right with this? I hope you're learning some shit. All right, now, so that's that. Flip the page. And we have this pitiful lady, don't we? She's looking happy though. Oh wait, you know what? Go back to that AEIO. I want to give you one more thing on that. I want to talk about dialysis a little bit for the acute kidney injury. Let's say that your patient came in and they were getting a cardiac cath, they're a diabetic, they were on metformin, and you were boo-boo the fool. Stuck on stupid, parked on dumb. Not my babies, somebody in the streets. Okay, so they admitted this patient, 53-year-old, cardiac catheterization, they're diabetic, they took their metformin, nobody told them not to, boom. You didn't even ask what meds they were on, you just prepared the patient for the little cardiac cath, put the 18-gauge IV in at a 15-degree angle, and you think you ready. You ain't asked her nothing about no metformin, you asked her what med she was on, but you didn't ask her if she took it. Are you still with me? Now, what do you know about a diabetic? What's the number one complication? Kidney what? Failure. What is contrast dyes? Toxic. What is metformin? Lactic acidosis, if you on it when you do the contrast dyes. But you don't know none of this because you went to a shitty school and never saw me. So you got this patient, you done admitted this patient, she's getting ready for her cardiac cath, she gets her cardiac cath, and she goes into AKI based on diabetic status and shitty kidneys, metformin not picked up beforehand and she took it that morning or the day before, and the fact that she had contrast dyes, which is extremely toxic to the kidneys. That's what you got. Now you get this patient, she's in acute kidney injury, she now needs dialysis yesterday. Does she have time for y'all to put an AV fistula and all this stuff that goes in people when we're doing chronic kidney failure? No. So how are we gonna do her dialysis? Through a central line. It's gonna be called continuous renal replacement therapy. So far so good? Continuous renal replacement therapy. Done in the ICU. It's going to be a Quinton catheter. It will have a red and a blue port. So I'm going to write that down. Quinton catheter. It will have a red and a blue port. It's in the subclavian, so it's a central line in the subclavian. Is it tunneled or non-tunneled? Non-tunneled, because you had to put it in right away. You didn't go to surgery and get a port and all this. It's a non-tunneled central line. It has a red and a blue catheter, a red and a blue port rather. What does blue usually mean in a textbook? Does it mean artery or venous? Venous, you better remember that. What does the A mean? I mean, what does the red mean? Arterial. So question, if we have a patient and we have a red and a blue port, does the blue port mean from the dialysis to the patient or from the patient to the dialysis? Venous. Which one of those does it mean? Does it mean dialysis to patient or patient to dialysis? What does it mean, Janae? What does it mean, Rhonda? What does it mean, Shiva? What does it mean, Cynthia? What does it mean, Felicia? What do you think it means, Katie? Dialysis to patient wins. Remember, venous to the patient. Artery away from the patient. You're gonna screw something up in this damn ICU you wanna work in so bad. You need to know this Quinton catheter, this subclavian central line, red and blue port. Blue, dialysis to the patient. Red, patient to dialysis. Okay, all right, now, so that is dialysis, right, for that patient. Now, you're the patient, you're the nurse in the hospital, you get the call that the patient needs dialysis. What types of things do you need to do to prepare for dialysis? Well, number one, if it's a diabetic like this patient was, you're going to make sure they eat really early. They're going to eat an early breakfast. Right before dialysis, they'll get their insulin. Why? Because dialysis increases blood sugar. You're going to hold medications, certain medications this patient cannot have. Let's see if you know your shit. Give me a medication they can't have before dialysis, y'all. Rhonda? What can they not have before dialysis? What you gotta hold? You just said it.
Oh,
Metformin?
no. Blood pressure.
Shiba, oh, blood pressure, that's good, that's better. Blood pressure meds. Shiba, give me another med they gotta hold.
Anything that vasodilates or
I need a medication. Rachel, give me a medication. Okay, you said BP meds already, beta blocker. Give me a medication you gotta hold, Kim. Metcalf, anticoagulant, you need to sound like a nurse. What is you doing? Blood thinner, sound like I'm a kinsman. Okay, what you got, Rayshana? What you got, Brianna? What you got, who is that down the hall and through the woods? Baby girl, I wrote your name down today. What is your name? Tatiana. What do you got? What are we holding? Y'all pitiful. Katie. Dariana, no. Aha! There go my baby. Water soluble vitamins. That sounded cute. What the hell is it, Dariana? Give me some water soluble vitamins. She loves the D. You didn't get that right. Okay, what you got? No, I said D ain't it. You still saying the shit. Eddie, water soluble vitamins. All your B's and your C's. Get your life together. ADEK is fat. Addict, fat. You can have those before dialysis. So you held blood pressure medications like beta blockers, ACE inhibitors, whatever. You held anticoagulants, we're gonna figure out why. You held water soluble vitamins because you knew we taking water off the body. We're gonna take them too. Give me some more love, Stephanie. What else we holding? Janae, what we holding? Eddie, what we holding? Y'all didn't get the main one, the number one. Ola, what's up? Say it loud. Digoxin. That's the main one, y'all. What's up? Now, Cynthia, big bad and bold. Why'd you hold the ditch? No. Why did she hold the ditch, Sarah? Why did she hold the ditch, Felicia? No. Josh. Why did she hold the ditch, Dariana? Glad y'all here. Janae?
Because if you're pulling off all the fluids, you're taking K with it, so gives you detoxin.
Exactly. If you have a dialysis patient, you are removing fluid from the body, and you're also removing potassium. When potassium is low, DIG is high. When potassium is low, DIG is high. Now, peep this. You know about the water-soluble vitamins. You're taking water, you're gonna take the vitamins. Why did I hold the anticoagulant? Harjo, why did I hold that? Why did I say no, baby? Don't take your baby aspirin. Don't take your Coumadin right now. Why did I hold it? Monique, why did I hold it?
Because if you give the patient the anticoagulant, like heparin, they're still gonna take you when you get to the dialysis.
When we prepare you for dialysis, we give you heparin. We don't need you doing double whammy up in here. So we have to hold whatever you're on because we know what we're gonna do. We can't afford for your blood to clot at dialysis, so you're gonna get an anticoagulant then. So we better hold whatever you're doing. Make sense? Okay, now, you said blood pressure meds. Is this list complete, or should I add one more category of drug? What else could I hold? Think about this. It's related, but it's not that. Toya, what you got? What you got, Ola? What should I hold? Isn't that already up there? I said blood pressure meds. It's another category of drug. That's a blood pressure med. It's another category. What'd you say, Robin? What else should we hold? Diuretics. Excellent. Isn't every patient on a diuretic? All these patients on diuretics, aren't they? You better hold it. What do diuretics do? Take your fluid, your potassium, and your damn blood pressure, drop it. You're gonna crash the patient if you don't know this. Okay? Now, when we do dialysis, our first nursing action after dialysis is check the blood pressure for obvious reasons. When we do dialysis, the first nursing action is to check the blood pressure for obvious reasons. Your patient could experience all kinds of problems. Dialysis is extremely bloody. Do something wrong, they can hemorrhage out. Dialysis is also unfortunately done in institutions where you have people that are trifling. 99% of all dialysis centers are wonderful. My father goes to one. 99% of them are wonderful, good, wholesome people. LPNs that care, RNs that give a shit. But every now and then, you'll get a dialysis center where there's a million call-offs, the people are not as, conscientious, management don't give a shit, it's all about the money. I don't know if you noticed, but a dialysis center is going up on every single corner of America. They even got them on the cruise ships. Well, that's nice, but if you don't have conscientious people, the kind with integrity, when you get call-offs, you still got all those patients to see. So now what are you doing? You're flipping the machines too fast because you ain't got no help. So you ain't cleaning nothing real well at all. And when you're not cleaning these machines really well, the dialysis patient gets hepatitis B and C. Hepatitis B and C, particularly C. If you don't watch your personal protective equipment and protect yourself, this is how the nurses got Ebola. Because with Ebola, dialysis is done. It's a very bloody procedure. They did not protect themselves well. They did not know how to remove PPE, and they got Ebola. They didn't know how to put it on right. They didn't know how to take it off right. They got Ebola. You have to remember your infectious disease principles and how to protect yourself. Okay, all right, so dialysis, right? It's not without risk. It's got a lot of things going on here. You could go into hypotensive crisis. You could become fluid volume deficit, shock, that. You could have something called a disequilibrium syndrome. These are the new patients that get dialysis. They're not used to it. Disequilibrium syndrome. My father experienced this. So disequilibrium syndrome means that the dialysis is too strong, too fast. We're gonna have to adjust the rate. This is a brand new patient, they're not used to all this. Or a pediatric client, disequilibrium syndrome. So we're gonna have to slow things down, okay? Now, how would you know? How would you know the patient has this? They're dizzy, they get a headache, they get nauseated. They can have a seizure. Hopefully not, right? We want to catch it early. Your first action, stop the dialysis. Notify the doctor so you can get a prescription or an order for mannitol. Because the real issue here is the patient's going to go into cerebral edema. So the patient, again, the blood pressure drops really fast. They're going to get dizzy. They may even get a headache. They're definitely going to get a headache if it's later in the process. They're going to feel nauseous. They're going to be looking all crazy, anxious, restless. They don't know what's going on. They don't feel right. Okay? The patient, your job, first nursing action, stop the dialysis, notify the doc, get some mannitol. Mannitol is an osmotic diuretic. Okay? All righty. Flip the page to the lady still smiling. Why do you think she's smiling? Because ain't shit funny, but why is she smiling, y'all? What is going on with her looking like it's all groupie? Well, why is she smiling? What do you think? She has no symptoms. She's in kidney failure, but she has no idea. So she's still smiling. That's what you better remember about this page. It's a very gradual process. Chronic kidney disease, CKD. Chronic kidney failure, very gradual. 10, 15, 20 years. Gradual. Some of you may be sitting here with it and don't know it. I've diagnosed in the room before people that are having signs of early kidney failure. Just education, so powerful. Just knowing your shit can save your kidneys and your family's kidneys. So let's look at this lady because she's looking way too happy. We have lots of wonderful things on the page. Number one, pay attention to the words at the top. Alternative language for CKD is diminished renal reserve when you're only in stage 1 or 2. This patient is early. Stage 1 or 2 is simply diminished renal reserve. If we play our cards right, she can save her kidneys, and this will never be a cause in her death. But we gotta catch her here. Now, let's look at glomerular filtration rate. Let's make sure we know all of us in this room should have a glomerular filtration rate between 100 and 125. So far, so good? All of us in this room should have a glomerular filtration rate between 100 and 125. She still has a fairly decent rate. It's around 90 or a little bit higher. So she doesn't know anything is going on so far, right? She doesn't know. Now, we need to remember facts. We need to remember that as you get older, especially 65 and older, your glomerular filtration rate drops naturally. That's why we had a conversation in class the other day about Joan Rivers. She was 73 years old. She was tiny. She's at the getting surgery done. We had to remember as nurses, her dosaging might have needed to be cut in half because she can't clear drugs out of her system. So when you look at someone that tiny and that old, you need to remember the dosaging that you're giving this patient may need to have been cut in half because they don't have the greatest glomerular filtration rate and therefore they can't clear those drugs. And they stay in the body and become toxic, fatal. Okay? Now, if you look a little bit longer, go down to the next one. It says observation and control of blood pressure. You knew that. You knew that the number one cause of chronic kidney failure is hypertension uncontrolled. The problem with hypertension, it's silent. Silent but deadly, my big mama used to say. Because you ain't walking around thinking, oh Lord, my blood pressure high. You don't know it first. You don't know it first, right? So it's silent but deadly. Now let me help you with this. Use that little area to put the top 3 reasons why people's kidneys fail and they end up on dialysis. Number 1, always tied with number 2, tied. Uncontrolled hypertension is tied with diabetes. Those are the reasons why people get dialysis and kidney failure. Number 3, something you don't think about as much, who knows what it is? Which one of you guys know? You might know. Darnita, what is it? 3rd reason for dialysis. Lupus. Excellent. Lupus is the 3rd reason. Most people don't know that. In fact, the number 1 cause of death for the lupus patient is kidney failure. Okay, so you better know your shit here. Okay, keep it moving. We're down to the 24-hour urine for creatinine clearance to detect loss of renal reserve. What do we do with the 24-hour urine? What is the first step with your 24-hour urine, Janae?
When you wake up in the morning, you use the bathroom and flush it.
Excellent. When you wake up in the morning, you time the bottle for when you woke up and you go pee and flush that sample. You know why you flushed it? That was yesterday's urine. You peed it today, but that was from last night. Okay? Now you set the timer, right? So you put the time on the bottle. Let's say that you woke up at 6 a.m. Boom, that's when it starts. Now, you got to keep it cool throughout the day. Tomorrow when you wake up at 6, you use that sample that you pee and you put that in the bottle and you're done. That's 24 hours. You got to know that. So a 24-hour urine for creatinine clearance. Question, Jessica, will this 24-hour urine for creatinine clearance with chronic kidney disease, will that be high or low in the lab when they test it? Will the creatinine clearance be high or low? Do you agree, Cup?
No.
You don't? Defend your point.
With chronic illness being,
This is chronic kidney disease.
yeah.
You can't disagree with that pretty little girl unless you know your shit. Otherwise, you gotta agree with her.
I can't really do
You disagree but have no defense. You plead, what is it, contest, no contest, right? That's what she got. Okay, Katie, what do you think?
it. I agree.
You agree? You said, fuck that, I agree. What you got, Kason?
I agree.
You agree? What you got, Ola?
I agree.
You do? You ain't got no defense either, huh? Pitiful. Okay, what you got, Rhonda? Come on, Rhonda, you can't slow on the uptake now. You gotta talk fast.
I gotta agree, I don't have to.
You gotta agree, no contest. You got no contest going on. Yeah, I understand, baby. Rachel, what you got?
I'm gonna agree.
Cynthia, you ain't gonna argue?
I agree.
You don't wanna argue with me, Felicia?
No.
What you got, Sarah?
I disagree.
Oh, shit, Sarah in the house. What's going on?
Because you're not increasing that, so.
Woo! There you go, baby. That's what I'm talking about. You did not get rid of your creatinine. Remember, you gave me 8 functions of the kidney. It was supposed to excrete waste, creatinine, blood urea nitrogen, acid, uric acid. You didn't do it. So it's still in the body. It's not in the urine. The creatinine clearance is low with CKD. Gotta know it, y'all. Y'all gonna be all right. We're gonna get you together. But you gotta know this shit. In the urine itself, there ain't no damn creatinine. You ain't cleared shit. It's still in the body. Makes sense, don't it? But guess what, y'all? Peep this. When you draw the blood, it's high. Write it. Serum creatinine is high. Urine creatinine is low. Now, creatinine clearance, 85 to 135. Something you better know. Creatinine clearance is the most sensitive way to diagnose kidney failure, chronic kidney failure. 24-hour urine for creatinine clearance is the #1 way to diagnose CKD. Now be careful, because we got something called diagnose and we got something called screen. So let's do the screen. If we're screening for kidney failure, which should happen to every diabetic and did not happen with my father. In fact, when I look at his labs, I saw 11 years prior that he had this. Microalbuminuria. Microscopic amounts of albumin. What's albumin? Protein in his damn urine. Ain't nobody worked it up. So when you call me 11 years later, they told me I got kidney failure. They said my number is 19. What the fuck is you talking about? What? You don't just get kidney failure, Dad. What's up? That's what's up. Negligence. This was on his labs, his chart. I got access to all of it. And it said positive microalbuminuria his very first visit at that hospital for primary care. And no one bothered to use a 24-hour urine to diagnostically work it up. I need you not to be that nurse. I need you to be loud and proud and say, hey, when we dipped his urine this morning, it was positive for microalbuminuria. You want me to give him a 24-hour urine creatinine clearance bottle so he can start the process? Because that's what my nurses do. Wake up. We a team out here. What he don't catch, you better. Or you affect people like my dad. Now, so protein in your urine ain't never normal. It ain't never normal. It ain't never ignored. It should be followed up. I got somebody in my class now. They tried to tell her, you okay, baby, you cool. I said, oh, no, the hell you not. You better find you a nephrologist quick. Protein in your urine is never normal. Started it in pregnancy, continued on, not cool. So she's being properly managed with a nephrologist. Protein in your urine ain't never normal. That's some bullshit right there. Okay? All right, it's so simple to see. I mean, it's just a dip. My God, how ridiculous can it get? Okay? Now, so this lady, damn sure, is positive for microalbuminuria. Her creatinine clearance will be very low. She ain't cleared shit. Normal is 85 to 135. She ain't cleared shit. It's low. If you keep on pumping, you got up here at the top, kidney damage with normal or slightly higher glomerular filtration rate. It's almost like you got a calm before the storm. It's almost like your kidneys are trying extra hard to do the damn thing because something ain't right. That's how you gotta look at that. They still trying extra hard. So far so good? Okay, now go down a little bit, and this is where I lose my babies. If you're not careful, I lose you right here. It says decrease urinary concentration and nocturia. Is the specific gravity high or low? Shout it out now. High or low? Don't make me call your name. High or low, everybody? Think it's low? You won that one that time. I need you to associate concentration with specific gravity. If the concentration low, so is the specific gravity. So what color is the urine, everyone? Excellent. Now get this. The very first sign, make it plain in your notes. The very first sign of kidney failure is getting up at night to pee. Now before you call me, text me, Facebook me, and Instagram me, and tell me how your little ass got kidney failure, I'm gonna tell you to stop right now. I'm telling you, you got up more than once. Generally 3, 4, 5 times a night. I had a young lady that was sick. She was sitting on the little blue couches in the projects. She was like, well, wait a minute, Miss Shelley, I get up 5 times. She absolutely had kidney failure. I'm glad that we talked that day. So she got to the hospital, the doctor, her primary, and they sent her where she needed to be, and that early diagnosis is gonna save her kidneys. As it turned out, she has lupus. So I need you to know, when you get up all night long peeing, that shit is crazy. Now, think about what you're doing. Maybe your crazy ass took some HCTZ or Lasix at night. That was stupid. Don't call me with that, please. Maybe you're the type of person that you drink a lot of water at work and you got off at 11. Okay, yeah, your little ass probably will get up at night. But I'm talking about the normal sister or brother who just runs through the day shift day and then comes home, eats the dinner, and does whatever. They could not, should not, will not, better not get up 3, 4, 5 times a night. That is not normal. Something is very wrong. Okay, so pay attention to your body because that's the first sign. Could have caught that, we could have saved this woman's kidneys. Now, I didn't know nothing about this microalbuminuria with my father, but my mama, I know about her kidneys. She got diagnosed around 30 years ago, at least, with stage 1 or 2. 30 years ago, you already know how I roll. So you know she ain't nowhere but about stage 3 early, right now, 30 years later, because I don't play. Once I know, oh, we're gonna do things real different. My dad always had bananas on top of his refrigerator, drank orange juice every morning, among other things, because I didn't know. Watch your mom and your daddies. Watch them. It's your responsibility. Talk to them. This is very big. Why do you think there's a dialysis center on every fucking corner? Go to the hospital with your people. Watch what they're having done. Ask for the proper tests. I had no idea. You over there chilling like a villain, having a good time, traveling the world, retired. Kidneys are slowly dying. I had no idea. He ain't complaining. What is he? A man. They don't complain. Okay, all right? All right now. If you look at treatment of comorbid conditions, there we go. Diabetes, hypertension, what you gonna add? Lupus, there you go. Now remember everybody, something else I want you to know. Almost all of this shit, diabetes, hypertension, whatever, boils down to one big, huge, long, $4 word. And it starts with the A. What does your patient have? What word starts with the A that they all have if they got this? Say it with your chest, or don't say it at all. Atherosclerosis. Boom, excellent. What is that? You say that's a pork chop bacon sausage sandwich? Oh, okay. So that's a pork chop bacon sausage sandwich. Remember that? Remember the pork chop bacon sausage sandwich? So this is you with a clean artery in the newborn nursery. You was on some Similac or breast milk, your ass is cool. Now, this didn't look like this long, because your little ass went to college. And that's where you discovered wings and pizza. When you discovered wings and pizza and gorged on all of it, and especially right before finals, you are starting to develop a little bit of plaque around your inside of your artery. Do you agree? This was newborn nursery. This ain't your ass now. This was newborn nursery. Now, when you develop the plaque, the atherosclerosis, if you think of it, because this is what it feels like. I felt it, right? So it feels like lard in your artery, like grease, like hard butter in your artery, right? Okay. Now, so your ass in your 30s, it's you right now, in your 30s, late 20s, little 30s, you're starting to get a big old plaque on the side of it. You see it? It's real thick. It's going to be very solid. It's going to take the opening of the artery and make it what? Narrower, right? We're going to make it more narrow. And we're going to have, let's see, hold on. We're going to take that artery that you made smaller and require more pressure to push the blood through it. High blood pressure. Now, this happened from years of poor diet habits. You caught the elevator to 2. You drove your car down to the end of the driveway to check the mail. You rode around Walmart for a half hour looking for that spot by the door. You did that. Inactivity, right? Because what does activity do to a blood vessel? Dilate. Okay, so now we got sucky diet and we have no movement, sedentary lifestyle, so we stay basically doing nothing, okay? And what do we know? When you don't move, neither does your blood. So perfusion is not that great. If you got your ass up, start working out, you perfuse your kidneys and everything else much better. You feeling me yet? That's what this patient has, atherosclerosis, okay? It's going to probably be one of many things they have, because just like atherosclerosis affected your kidneys, it also affects your heart. Just like it affects your heart and your kidneys, it makes diabetes worse. Diabetes makes it worse. They just love each other. They can have a stroke, which is your brain. All of this is affected by atherosclerosis. Every bit of those things are affected by atherosclerosis. Okay, so you just know that some things just kind of gradually happen to our body parts, right, y'all? Okay, so your little pork chop bacon sausage and Mr. Hero Mickey D's Burger King self for the lesson. Now, what we got with this patient is we have to control these diseases. In this very early stage, we've got to monitor the blood pressure. This patient should be on the #1 drug in America for kidney failure or diabetes, ACE inhibitors. This patient should be on an ACE inhibitor. And you know why? Because an ACE inhibitor is going to prevent vasoconstriction, and an ACE inhibitor is going to prevent fluid volume overload, and fluid volume controls blood pressure. This patient needs to be on HCTZ, a diuretic. Let's get rid of water. It controls your blood pressure. maybe even Lasix, right guys? But usually HCTZ, ACE inhibitor, those are really good medications for this patient. We need to discuss this situation with this patient, start talking about diet. You ain't gonna have no damn bananas on top of the refrigerator. You ain't about to be buying no orange juice ever, no ever again. Okay, you're not. You know what you're gonna get up close and personal with? Apples and berries. Not strawberries, because they're high in potassium. You gonna be all up in the apple section of the store. They got about 50 of them. Go find you some berries. Blueberries, blackberries, raspberries. Stay the hell away from strawberries. That's what this patient needs to be told now. Mama ain't got no damn orange juice in her refrigerator. If I go over there, ain't no way in hell. Be like, what is this? Okay, so that's you. Check yourselves before you wreck yourselves. What they got in the refrigerator? Look at them. Did they buy that scale yet? Because they should have. Once kidney failure came out of some doctor's mouth, they should have bought the scale. Go check on your mama's scale. Do they have a scale? They should. The scale, let me help you out with the scale. The scale will prevent almost every admission of pulmonary edema. The scale could prevent 75% of admissions for CHF. The scale could prevent almost every fluid volume overload that occurs. If you just weigh yourself every day, we can prevent so much. I teach you that your patient ought to be just like a new mom. A new mother freshly delivered knows, I can't go home unless I prove to the nurses that I have a car seat. And you guys are so good at what you do. You send me cute little pictures with your patients smiling, holding your scale, because you're so damn good at this. Your patients don't get discharged until the family picking them up show you the scale. And that's where you get the picture. It's adorable. That's how you ought to be. You gotta prove to me you have a scale, sweetheart. I'm not letting you out of this place. You're still in jail until your daughter shows me that you have a scale. Daily weights. Why? How much weight is bad in one day?
3 pounds.
3 pounds. How much is bad in a week?
5.
5. Don't forget, my mama called me. She said, I don't know what's going on. I done got all this weight in one day. You told me to call you if I gained more than 3 pounds. Well, it's 4. You know what happened to her? Her pacemaker had stopped working. What would have came 2 days later? Pulmonary edema or heart failure. Her pacemaker was only 2 years old. This was the last 10 years. Little malfunction here. Picked up early with daily weights. Daily weights. She needs daily weights. While she's smiling at everybody, she needs some daily weights. This is the most important thing. Simple, simple stuff. Okay? All right, now as you look at this lady, we're going to tell her about her smoking. Put your shit down. What does every cigarette do? Vasoconstrict. Going to shut off the blood flow to the kidneys and the heart and everything else. We need her to stop doing pork chop, bacon, sausage sandwiches, right? We talked about that. And toe to toe. We're going to need her to get herself together, start doing chicken and fish, leave that red meat alone. Pork ain't even in her house. Stop playing. They got them damn turkey sausages. I buy them, they better. Okay, you be all right. You get adjusted. Put them damn ham hocks down. Go get your neck bones. Chicken necks, okay, is better, right? Y'all feeling me on this? This is how you gotta talk to your patients, because they say turkey necks, chicken necks, whatever, smoked, whatever, I don't give a shit. It's got to be turkey, chicken, fish. They all up close with salmon. Trust me, I'm a really great Sunday dinner cook. I used to cook with all this bullshit. I don't buy it no more. I don't even buy it no more. Tastes good as that. And kids ain't saying shit. They don't even know. Mom, we coming home for Thanksgiving. What you making? They don't know. Okay, they ain't thought about what's in there. Oh, Mom, these greens. Yeah, I know, baby. I done changed up the game on them. They don't even know. Okay, so you want to make sure you teach your patient this. They don't just know this. You teach them. Okay, now make sure you know they gotta lose the weight because they're causing your kidneys to work extra hard. And what's a real appropriate way to do that? Start with portion sizes, walking after meals. Portion control is a big one. Why is you supersizing shit? What's wrong with you? Do you know if you go to China or Japan, where I send my daughter over there in China, they don't even have normal sizes. There's no 6-piece McNugget, they're 4. There is no super size nowhere in that country. You need to stop it. We're creating a nightmare here. No super sizes, stop it, okay? Now, your patient is now on medications because we're trying to preserve their kidneys forever. And this patient is making sure they don't do anything that could kill the kidneys off. They are going to be told to tell every doctor, dentist, whoever they come in contact with, I can't have nothing. I'm on kidney failure. Don't give me that 800 Motrin. I have kidney failure. They cannot take Motrin, NSAIDs of any kind, Advil, Aleve, none of that. If we do contrast dye, we gotta run a BUN and creatinine first to check it and see if it's appropriate. Isn't that right? So if they got a CAT scan with contrast, we can't do it unless we run a BUN and a creatinine first. And then if we run it and it's terrible, we're gonna have to call somebody because we can't do it. Okay, so these are things you know. So no NSAIDs, no aminoglycosides, no magnesium products, no orange juice. What's the highest potassium food? You think it's strawberries? Shiva, what's the highest potassium food? What's the highest potassium food, Rachel?
Isn't it like purple fruit or like iron?
Purple fruit was what you're allowed. What's the, that's iron. What was high in potassium, Cynthia? Okay, somebody said that. You wanna come again? Sarah? Felicia? Joshua? Dariana? Miss Katie? This is what I get every time I ask this question.
Sweet potatoes?
Potatoes, potassium. Potatoes, potassium. You better figure out and get it in your head. Potatoes, potassium. Potatoes, potassium. You're laughing now. Your little ass gonna be at NCLEX going, yeah! She said that shit. Now, P-O-T, P-O-T. Potatoes, potassium. Don't nobody ever know that shit. That's why I gotta dance and sing and shit. Damn shame. Stuff y'all put me through. Okay, now, so for real. Baked potato, bad. Sweet potato, bad. This is all high in potassium. It's the highest food in potassium. You think bananas is on some test? They know you know that shit. That ain't on there. So tomatoes, potatoes. Tomatoes, potatoes. Bananas, okay, yeah, that's cute. Oranges, strawberries, melons. Now listen, don't shoot the messenger. Chocolate. Chocolate. Chocolate is high in potassium. Honey. That's why chocolate milk is the drink of choice for athletes. Chocolate milk. Okay? All right, now get your life together. Turn the page, hell. We gotta make our patients sicker. Put at the top, stage 3. Chop, chop. Stage 3, sister girl, hit. She look like it. Look at her, she got a problem. She don't look happy no more. So here's our deal. Her glomerular filtration rate is less than 60. Starting to creep on down. GFR less than 60 for 3 months is called stage 3. Now, let me tell you something. This patient still does not qualify for dialysis and shouldn't. But look at the words now. She's no longer in diminished renal reserve. She's hanging out with renal insufficiency. Y'all good? She is at risk right now for a stroke, an MI. She's at risk for infection. Didn't we say that the kidneys metabolize vitamin D? Didn't we say that it produces erythropoietin? let's just look at those two. Let's just look at those two, okay? Do you see where it says anemia on the right side? Well, that's that erythropoietin. So if your kidneys cannot make erythropoietin, then you are going to be anemic because erythropoietin stimulates the bone marrow to make red blood cells. Now you don't make erythropoietin, nobody's stimulating the bone marrow, red blood cells are not being made, you are anemic. What does that mean? Look at her, she's tired. You know this, anemia is exhaustion. She's tired, she's dumped over, right? Things gotta make sense. We don't memorize shit, we gotta understand it. I want you to put on here, I will put it over at the, bottom on the left-hand side. Let's examine why she's at more risk for infection, because I don't think that people know that. This patient with this kidney failure, stage 3, like my mama, she's at increased risk for infection because get this, vitamin D helps our body recognize self from non-self. So if we get an infection, that's non-self. The vitamin D helps you recognize it. If I have great blood count and I'm not anemic, I can fight the infection. So when you're anemic, you don't fight infection very well. You knew that because sickle cell is always at risk for infection. So two things, the vitamin D issue and the anemia issue is going to make your kidney failure patient at risk for infection. So you know about that. That's why we said in class the other day, flu shot every year. Pneumonia shot every 5 years. Got to get their vaccines. Flu shot every year. This is the season, September, October is the season. And then the pneumonia vaccine every 5. This is a very high risk patient, okay? So you got to worry about that. Now let's look at some more stuff. Let's just go down the list. Hell, everybody in here is not in kindergarten. Most of y'all ready to test. So if you look at a headache, why does she have a headache? High blood pressure. We don't separate those, do we, y'all? We know that anytime you got a high blood pressure, you gonna have a headache. So far, so good? So anytime you have a high blood pressure, you're gonna have a headache. That's neuro. All neuro patients have those. Okay, cool. Now, ability to concentrate urine. Well, what's her specific gravity? High or low? Low. She doesn't have any ability to concentrate her urine. All the waste product is still in her body. Don't that make sense? Okay, keep it moving. This is going to sound really weird. Again, your kidneys are trying to give it the last good shot. So they do polyuria before oliguria. That's weird. You actually give it one more last try. You put out more urine trying to get rid of all this waste. You're like, dang, everything I do, I can't get rid of this waste. Maybe if I pee more, I can get rid of it. See? Don't that make sense? Okay, so polyuria first, then oliguria. You know the bottom, look at what it says. Increased BUN and creatinine. You know that, because in the blood, it's high. In the urine, it's low. Okay? Go over to the other side, edema. We're now starting to hold on to our water. We're getting edema. GFR, I told you it was 60. You see the high serum K, because you can't get rid of it. Now let's put some more with it. Not only do we have a high K, write this down, you have a high phosphorus. You have a high uric acid. You have a high BUN and creatinine. Get your highs together. High potassium, high phosphorus, high uric acid, high BUN and creatinine. Here's what is low. Low calcium, low albumin, low H&H, because it's dilute. Now, we did our highs and our lows. I left a leftover, like spaghetti. I want you to tell me the last one. You have to tell me which one it is. Brandy, is the pH of the blood high or low? Tasha, is Brandy right?
Yes.
Tysa, is Natasha right? Is Brandy right and Natasha right? They said it's gonna be high.
Yes.
Darnita, do you agree?
No,
Why?
you said they hold on to all the uric acid.
Excellent. There go my nurse. The pH is low because the patient's acidic. They're holding on to uric what? Acid. So they're in acidosis. This is select all. Okay, all right. Now the blood pressure's high, weak and fatigued, keep it moving. Oh, wait a minute, hold up. Look at her little lab slip. Y'all see it? See her little lab slip in her hand? She got the hemoglobin. What does it say it is? Oh, okay. Creatinine and BUN high. Okay. Turn. She real pitiful now, y'all. Hot mess. Ooh, wee. Look at her, y'all. She's pitiful. Okay, now this is what I need you to do. I need you to put on the top, dialysis occurs with GFR 15 and below, and the most important word here is and. Dialysis occurs when the GFR is 15 or below, and the most important word here is and. There are positive signs and symptoms. In other words, we don't just go by the lab. So when my dad called me and said his GFR was 19, that qualified him for an organ donor list. I wanted to donate my kidney, he wouldn't have it. I was pissed. So when you hit 20 and below, you go on a donor list. When you hit 15 and below and you have symptoms, now you go on dialysis. So my dad really did not have any symptoms, I told you that. And he really just kind of was clueless about the whole thing. So they said, well, we don't want to do dialysis even though you're running around 15. And he did get to 15, but we don't want to do it now because you still feel really good. And you know why. Once we start the nightmare, we can't stop it. And once we start, your freedoms are impacted. You just don't have the freedoms that you did. Remember, he's a world traveler. So he just doesn't have that ability because you kind of got to stay a little bit put, right? You got to do this shit 3 times a week, or if you're going to do peritoneal dialysis at the house or whatever. You're kind of tied to a machine or something, right? You agree? So we're not trying to start it until we have to. But yet, we don't want to wait until you're beyond recognition with your symptoms, because why? We've got to make sure we place a shunt. We've got to do a fistula, right? So either arterial venous shunt or AV fistula has got to be placed, or a peritoneal dialysis port. Isn't that right? Those take weeks to mature. You got to put them in way in advance is what you better know, because they got to get real tough, strong. There's got to be scar tissue building up on purpose. We want that either in your peritoneal dialysis port or your AV fistula. We want it strong. It's got to accommodate a lot of blood, so we want it strong, okay? So we put it in advance, weeks in advance. You can't just do it tomorrow. No. So my dad, you know, he had it in January. He didn't start dialysis till like June or something or whatever. Okay, so we're going to be a little while waiting on it to mature. It's called mature. Okay, so you did have to know that about this lady. Now, we got some rules. Oh my God, we got some rules, y'all. We want for this patient to always have a bruit and a thrill. How do nurses listen for the bruit? Louder. The bell of your stethoscope. You better know that. B for bell, B for bruit. So far so good? You're listening with the bell of your stethoscope. B for Bell, B for Brewy. Okay? This is what you're going to teach your patients, because a Brewy is a nursing issue, isn't it? But you're going to teach, keeps people out of the hospital. You're going to teach your patient that when they wake up every single freaking morning, they're going to take their hand and they're going to put it on that AV fistula or shunt, and they're going to feel for the thrill. Now, I teach them because I like comedy and humor. I said, now listen, if the thrill is gone, it's an OMG emergency, right? You gotta teach like that. They'll remember it better. If the thrill is gone, it's an OMG emergency. It is an emergency because it's not working. It means it clotted off. It means I can't do dialysis. It means that your potassium is gonna go up. It means that fluid volume overload is coming. It means that pulmonary edema is close by. Know it. If the thrill is gone, OMG emergency. That's how you gotta look at that. Brewies and thrills, gotta have them. Okay? Now you won't have brewies and thrills issues with this whole peritoneal dialysis stuff. You won't have it, okay? It's really hemodialysis, all right? Now, so let's think about those two, shall we? Peritoneal dialysis is done in the home. So my father chose to do that for years, and he did until he got peritonitis. Number one complication, peritonitis. You don't even qualify for peritoneal dialysis unless a family member, your spouse, your kid, somebody signs that they will be responsible to do it if you can't. So both of you go through intense training. So nurses came to Dad's house, they taught his wife, they did all this stuff. So you have to have someone signing on. Peritoneal dialysis is wonderful for the time frame it's done, but the way I understand it from all the doctors I've talked to is everyone eventually gets peritonitis. Now, peritonitis can be life-threatening because it can lead to sepsis. Why? Because peritonitis is GI. What do we teach you? All GI is dirty. So if you were to become septic from the E. coli and everything else, oh my God. So we don't play with no damn peritonitis. How would you know your patient had peritonitis? What would you see? Cloudy fluid. Remember my rule. If it comes out of the human body cloudy, it's infected. If it comes up from pharmacy cloudy, it's contaminated or it's in pH. So this patient that gets peritonitis, they're gonna have cloudy fluid. The fluid that comes out of the patient is called effluent, okay? Effluent, that's what it's called, effluent. So your patient, my dad, is getting supplies sent to the house. The supplies that are sent to the house is called dialysate. He is going to sit down in a lounge chair, positioning matters here. He's going to sit down in a lounge chair. He's going to fill his belly up with dialysate, about 2,000 cc's of whatever. And when he does that, he's going to let it sit. This is called dwell time. Now, I know on UWorld they had dwell time, half hour. That's for that patient. Dwell time is determined by the physician. It could be 4 hours. It could be all night long. If you go to sleep with the dialysate inside of your peritoneal cavity, which lots of people should do, and then they wake up and empty it, boom, your dwell time was about 8 hours. Dwell time simply means how long did it sit? And it can just sit, it's no biggie, okay? Now, it acts like an artificial kidney. You needed to know it's hypertonic. Dialysate is hypertonic. Sterile technique must be done. If someone's helping them, the husband, the wife, both must have on a mask and a cap. If you're doing it at the hospital with your patient, the patient and the nurse must have a mask and a cap. Sterile technique. Aseptic technique, right? You gotta know the other words. All right? Okay, so you're filling up with your dialysate. You're allowing it to dwell inside of you for however long the doctor ordered. And then you are draining into the bathtub or a bucket usually because you're sitting in a lounge chair. You're draining this fluid and it's called effluent. Now, that effluent, what color should it be, Jessica?
Should it be clear?
Just plain old clear, or should it be colored?
Well, colored is good.
What colored, what color? Should it be pink or tan or red or yellow or brown, or what color should it be?
Maybe yellow.
You want it to be yellow? Do you agree with her, Rhonda? Why? What color would you like it to be? Tan, red, pink, yellow, brown? You want a pink? What color should it be, Shiva? You like pink or yellow or another color?
We'll go with yellow.
Okay, we're gonna do some Crayola up in this motherfucker, Miss Metcalf. What color you want, baby? Which crayon? Tan. What you working with, Felicia? Yellow. What you got, Josh?
You say pink.
Pink. What you working with, Dariana?
Yellow.
Okay, now listen. What the hell? You got rid of urine. Urine is yellow. Here's what you teach your patient. Teach your patient that dialysis removes urine out of blood. Because before you had it, your urine was in your blood. That's what you better teach them. So since it's removing urine out of the blood, then it better be clear yellow. It may even be more pale, whatever, it's urine, okay? Keep that in mind. It ain't pink, last I checked. Unless your pee is pink, then you need to holler back at me on the break. Red, hell to the no. Tan, oh shit. Literally, you shit. Okay, so there's some perforation. Okay? So if you have pink, pink means the patient, if they're a man, there is a small tear or perforation. If it's a lady, maybe they're on their period. You better ask. If it's red, oh, well, you know what that means, right? If it's brown, oh, that means that there's also some type of contamination with stool. There must be a little tear in there somewhere. Poop is getting through. Cloudy means infected. You feeling me on this? Hope so. Hope so. This shit is hard. Okay? Now, so if you put the dialysate in and you get 2,000 cc's that you were ordered to put inside, what should it be when you drain the effluent? How many cc's? Hello? 2,000? Everybody cool? Darnita, you cool? If you put 2,000 in, should you get 2,000 out? You should get more. Yeah, because you should get the 2,000 that you put in, plus all the fluid from the body that you put it in there for. Might want to know that. Okay. Know the terms. Dialysate, dwell, effluent. Know the colors, know the amount. Kind of important. Okay? All right. So let's look at what this poor little lady is suffering with. We have 2 different diets. Before, and you got to make it plain in your notes. Before dialysis, you have a renal diet. Before. In other words, you're not getting dialysis yet. You're healthy enough not to go on dialysis, but you're sick enough to need this diet. This diet essentially gets stricter with each stage of kidney failure. But some things started way back in stage 1. Remember? No bananas on the refrigerator. You feeling me on that? Okay, so here we go. Before patients order any dialysis, everything is low. Low sodium, no shit. Low potassium, yeah. Low protein. Low phosphorus. Fluid restriction. restriction. Now, I'm not gonna restrict fluid in stage 1 and 2, but I'm damn sure gonna restrict fluid in stage 4 and 5, like in stage. So fluid restriction. So think it through. You can't get rid of fluid. Why would I give it to you? I ain't gonna give you that much, right? So how do I base how much you can drink? On yesterday's output. Whatever you peed out yesterday, add 400 to it, you can drink it today. So if I put out 500 cc's of urine yesterday, if I add 400 to it, I can drink 900 cc's today. Your intake today is based on your output yesterday. When it comes to sodium, you'd better know what we tell the patients. What do we tell them? What do we tell them? Darnita, you whispering. That don't help me at all.
I don't know.
Say what the hell you said, shit.
I don't know.
What'd you say, baby? You're probably right.
But they need to have the, they can't do, low sodium, but they can't have a Mrs. Dash.
Oh, that's what Rhonda was saying. Mrs. Dash is not a potassium issue. They can have Mrs. Dash, it's all natural seasonings.
Okay.
They can't have salt since because of potassium, so that's not a sodium issue. What do we tell patients with low sodium? How do we teach them about low sodium? What do we say?
Take some drink, no additives.
Read the
Read the label.
Read all labels. Very nice, Sheila. These babies don't know nothing. Sheila came to save you. Now, here's how this works. Y'all know I've been married 17 times. Y'all all right? We just gotta be honest with each other, a little transparent and shit. So I've been married 17 times. One of my husbands had hypertension. I actually liked him at the time, so I decided that I wanted to go to the grocery store, shop like a real good wife of somebody with hypertension. I'm going here, I'm doing some low sodium food, I'm come home, cook this shit with no salt, that's how we're gonna roll. Like I said, I liked him at that time. Now, I get to the grocery store. I spent 20 damn minutes in the bread aisle. It was a mind-blowing experience. Because I'm in the damn bread aisle and I got bread, and that's for one piece with 380 milligrams of sodium and as low as 80 milligrams of sodium. This is all bread. And remember, I'm trying to find 100% whole wheat for obvious reasons. So I'm looking for bread. I done spent I ain't got time like that. I spent 20 minutes in the bread aisle. Thank God my old ass had my reading glasses like Sanford and Son, because I'd have never read that little teeny tiny print on the damn label. These patients gotta read every label. So if I'd have bought the wrong bread, which hindsight is 2020, when I found out I didn't like them no more, I should have bought the wrong bread. But at the time, I didn't know. So I ended up spending 20 minutes before I found this one. That's just bread. You got a whole fucking store to go through. Wow. This patient can rank up their allowed sodium in a sandwich. If you take these 2 pieces of bread, you now have 760 milligrams of salt. How many milligrams is your patient allowed? 300? What the fuck? In a day? What is 2 grams? 2,000. Wrong answer. That was old news from your old school. They changed that shit 5 years ago. You better know it. You allowed 1.5 grams or 1,500 milligrams. Knowledge must be updated. That 2 shit is old. Now listen. 1,500 milligrams. I'm gonna kick the hell out of 760. Y'all with me? Half of my daily allowance was in a sandwich. I didn't even look at what the hell to put on it. I just ate 2 pieces of bread. I don't know nobody doing it like that. You want something on your sandwich. That's how bad this is. That's how bad it is. So guess what? You ain't finna eat no damn bread. Bread is the most common hidden salt. It's hidden because you don't even think like that. This patient don't need no bread. Bread is a hidden salt. Dairy salty. Okay? If you buy it in the middle of the store, the shit is salt. Boxes, prepared, frozen, cans. You better shop on the outskirts of the grocery store. Fresh foods, right? So salty foods are frozen, canned, boxed, prepared already, and bread. Those are salty foods. But she was right. The bottom line is they gotta get their damn reading glasses and read all labels. Because that's really how you stop this madness. Okay? All right. So now, let's do hemodialysis. Just little tips. We already did what to hold. I want you to know with hemodialysis, the worst thing that can happen is that they clot off, right? So what you gotta remember, babies, is you gotta remember with hemodialysis, the patient has to wake up and feel for that thrill. The nurse has to make sure she hears the bruit. All this is happening every time they come in. And then don't forget, Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. When they miss one of those days, they miss taking urine out the blood, it will poison them. They will go into what we call uremic frost. Uremia is really horrible. The patient has a fluid volume overload, needless to say. They are able to have a seizure. Their skin will look olive gray, yellowish colors, horrible, y'all. I didn't see it. So we had a home care patient. The daughter and her man was on some bullshit. She always made sure her mother got to dialysis. Monday, Wednesday, Friday. We got home health aides going in helping mom. She decides she want to take a Christmas holiday. She figures mama will be fine. We just gonna go away for the weekend. They made sure that she got dialysis on Friday before they left. Now they planning on being back. They didn't make any second kind of plans or anything. They got stranded because of a blizzard. They didn't get back on Monday. They didn't come back till Thursday. She's missed Monday and Wednesday. The aide goes in on Tuesday and says, and calls me, Miss Shelley, she green. She don't want to get out of bed. She says she too tired. No shit, Sherlock. She real swole, Miss Shelley. That's insanity. She's missed her dialysis. This is Tuesday evening, about to be Wednesday. Doesn't take long. Soon she will have what? Pink, frothy sputum. So she had to be admitted. Yep. Okay. And we almost put a adult protective services call out because this woman was over 65 and this is considered negligence on the part of the daughter. But when she explained all the things that went down, it's like, okay, got one chance. You're supposed to make a backup plan, daughter. This is your mother who you signed that you're responsible for. Okay, so don't do dumbness. Hemodialysis every other day. Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. Okay? All right, let's keep it moving. I want to finish rhabdomyolysis that I hinted about. We already know it is destruction of the muscle that causes renal failure, right? What was our first nursing action? Hydrate. We already told you the reasons why. Now let me give you what your labs will look like. What I want you to do with rhabdomyolysis, I want you to, if you look at this page, I want you to go to creatinine clearance, right at the bottom. The next couple pages, right at the bottom. We'll talk about the new one in creatinine, but right there at the bottom. Just write it right in here. It's a short little deal. At the bottom, where my fingers are pointing. Gotta look up here, you're gonna be lost. So just write rhabdomyolysis, it's real short, okay, because you already know the cause. We told you statin drugs, prolonged bed rest, excessive exercise. It's a type of acute kidney injury, right, y'all? Okay, now come on. You done hydrated the patient first, that's a beautiful thing. The labs come back looking retarded. What's high? Common sense. Kidney injury. What's high? What can you not get rid of? So high K, high uric acid, high phosphorus, and get this, problem child, low calcium. Put a star by that low calcium, please. So you got an electrolyte nightmare. High K, high phosphorus, high uric acid, low calcium. What does this automatically mean you better do when they come in? EKG. EK. K for what? Phosphorus. That's why I don't go to ECG. I don't care. I say EKG the old-fashioned way. And I keep it EKG for y'all. Because EKG, which is an ECG, means K for potassium as far as long as you live. EKG. Okay? All the time. If a K is bad, it's going to be an EKG. And it doesn't matter what kind of K. It can be high, it can be low, EKG, boom. Now, what are you going to see on the EKG for this patient? Peaked T waves. High potassium gives you a peaked T wave. Think of it like this. The peak of the mountain is the highest point. What's your potassium? The highest point. Uric acid. What kind of acid-base imbalance, everyone? Metabolic acidosis for this patient. Phosphorus. Phosphorus is going to harm the kidneys. What is the opposite of phosphorus? Calcium. So when phosphorus is high, calcium is low. Calcium. This is what I tell you. Me and you went to Walmart. Not together, I just happened to see you. I know you don't believe me because you don't know what I do and you don't know how I roll. But honest to God, when I see you years from now, and you be trying to run from me. Ramen Deep tried to run from me in H&M. I saw her in H&M over at Beachwood Mall. She tried to run from me. She's like, oh God. Yeah, she tried to run because she knew what it was. She knew when I saw her face, I was going to holler something out and she was going to have to respond. Now, it depends what I'm feeling that day. Sometimes I'm feeling a neural spirit. And I say, hey, neuro. And then you say, high blood pressure, headache, irritability, seizures. Well, sometimes, y'all, I be feeling a hypocalcemia spirit. I do. Like right now. Hold on. I got you. I'm feeling that spirit. I've got that spirit. Oh yeah, it's feeling good. Oh yeah. Your patient got a low calcium. I see your ass in aisle 10 in Walmart. I'm in aisle 4. Hey, how you doing? How your mom and them? Hypocalcemia. What should you say? Technique.
TTRs.
What's next? Shabastics. What's next? Trousseau's. What's next? Brisk DTRs. If you have brisk DTRs, you gotta do one more assessment. Clonus. Only if you have brisk DTRs. What do all this add up to? Seizures. That's what you gotta know about rhabdomyolysis. Hydrate first. Hydrate first. Now look, y'all, we said the patient had a high uric acid, right? What kind of medication can we use for that?
Allopurinol?
Allopurinol, says people who are confident. Instead of whispering. Allopurinol, look, lowers the purine. When you have allopurinol, urine, uric acid, low purine diet, low purine, it's in the word. It's in the word. Okay? So you're going to make sure you know allopurinol may be the medication we use. For the high K, what could we use? What is that generic, nurse? Exactly. Anybody know? Because that's what's on your test.
Polystyrene.
Sodium, polystyrene, sodium, sodium polystyrene, whatever. You better know it. Okay, moving on. Keep it pumping, pimps. Now, so turn the page. You got a kidney transplant patient. Now, you ain't gonna put much on here. Is that the one you got? Is that what y'all got? Kidney transplant? Yes, no, maybe?
Yeah.
Okay, here we go. Look at it. You are very interested in knowing what the heck is going on with this patient. I love this picture. On the picture, you've got a kidney falling out of his stomach. Does everybody see it? That's what you better remember. Kidneys are put in the stomach. When we transplant this patient, the kidney is put in the stomach. So we transplant it right in the pelvic area, the tummy area, and we know that you will protect it better that way. We do not take yours out of your back. You just got some old piss poor pathetic kidneys that's still in your body. But your brand new kidney, we're gonna put it right in your stomach. So when there's a rejection and we gotta remove it, it's gonna be abdominal surgery. A little easier than your back. You feeling me on that? Okay, now the other issue is when you have a rejection, there's several types. You care about this one over here that says acute because it's the most common. Highlight what it says, not uncommon. Highlight it. Generally speaking, we do not take the kidney out for that. We manage you through it. We don't take it out for that. We do have to take it out for some of these others, but we do not take it out for that one. Okay, we try to manage it. What kind of medication do we put you on so that you don't reject your kidney? Immunosuppressant medications. What does that mean to you? That means every kidney transplant patient is immunosuppressed. The category of medications, you know one of them. What's the most common immunosuppressive category of drugs? Steroids. Good. So steroids is one. Right, guys? We got our little steroids. So let's make sure we write that down. Steroids. Then we have something called DMARDs, remember? That's not the most common. That was not the right answer. So steroids are the most common. DMARDs are the next. And then we have something called monoclonal antibodies. This will always end in MAB or SEPT. So you kind of want to know that. CellCept is a very common medication for this patient. Monoclonal antibodies. Now, diagnosis of rejection is a kidney biopsy. Yes, you care. Diagnosis of rejection is a kidney biopsy. Turn the page. Glomerulonephritis. Glomerulonephritis is a condition in which you can see it has nephritis in there. So what's affected already? Kidneys. Kidneys are affected. Now, for glomerulonephritis, very often it is a child, but it can be an adult. What I want you to do at the top of this page is I want you to write antigen, antibody response to strep A. Antigen/antibody response to strep A. If you were here in toe-to-toe this Saturday, you know that. You also know the classic hallmark symptom. What is it? For those who was here. Tea-colored urine. You better know that. So for this patient, Tea-colored urine is a classic hallmark symptom. Now, I always have you put a little triangle, and it really helps you. Don't we call it triad, y'all? So at the upper right-hand corner, a little small, don't make it too big, it ain't that serious. Make a triangle, y'all. Make a little triangle over there. And here's what I need you to put. I need you to put tea-colored urine. And don't be so ridiculous with it, okay? Because I can't take y'all when y'all be absolutists. It didn't say tea-colored urine on mine. It said smoky. It didn't say tea-colored, it said coffee. It didn't say tea-colored, it said rust-colored. It ain't yellow. So tea, rust, coffee, smoke, I don't give a shit. It ain't yellow, it's a wrong. Okay, so tea-colored urine is a good one to know. It's number 1. It's called classic hallmark. And then put this on the side. If I say the patient has a high blood pressure, what else they got? You want to say it with your chest? Oh, okay. All right. Okay, now at the bottom, y'all, keep this. History of a sore throat within the last 3 weeks. So what is that? Strep. Whether they went to the doctor or not, that's probably what it was. One of my little babies was in college when she got this. She had finals. She wasn't finna go to no damn doctor. She didn't like the campus health services. So she was like, bump that. I gotta get through finals. I'm in nursing school. Can't miss no days. She gotta be on campus for that. So she was like, okay, I know what I'm gonna do. This sore throat is driving me crazy. When I get done with finals, I'm gonna go home and get it together. Go to my regular doctor. How long do you have to wait before you get into trouble? 3 to 5 days. You sitting around with that sore throat 3 to 5 days, you too can have glomerulonephritis. And that's exactly what she got. Glomerulonephritis, untreated, undertreated, delayed treatment of strep. Untreated, undertreated, delayed treatment of strep. Okay? Now, you know if your kidneys ain't working, you're going to have a fluid volume overload. You know if you have fluid volume overload, your blood pressure go up. You know if your blood pressure go up, you're going to get a headache. That's all they're saying on here. You know if you got a fluid volume overload, you're edematous. You know this. We can keep it moving, really. So look at it. You done gained the weight. You're edema. You got everything wrong. What I say is always a sign of kidney failure. Protein in the urine. That's on here. Kidneys are failing. You don't make urine. That's on here. It's called oliguria. What is the tea color, rust color, cola color? What is that? Blood, hematuria. It's on here. It makes sense. Don't be acting crazy. Brand new. Okay? Now, what I told you to write at the top is in a box right here. Antigen, antibody, group, strep infection, complex from recent strep infection. What kind of strep? Strep A. What is low? Glomerular filtration rate in this box. Low glomerular filtration rate. Highlighted. The patient may be pallor. The edema is around the eyes. It's called periorbital. Periorbital edema. Now, what you're going to do with this patient? Well, you're going to monitor their blood pressure. You may have to give antihypertensives. The patient's on bed rest. They're going to need immaculate skin care because swollen skin breaks down. If I was real puffy and I did this, I would tear my arm skin, the skin of my arms. I'm real swollen and I just did that, I would literally tear my skin. I would tear it. It's so easy for them to get a pressure ulcer. Very edematous skin needs skin care, immaculate skin care. Patient's gonna be on diuretics, steroids, renal diet, and often we give this patient Bactrim. What kind of pain they got? Where is it at? Flank, better be your word. Flank pain. Patients at risk for this, lupus and sickle cell disease. Patients with lupus and sickle cell are at risk for glomerulonephritis. Okay, at the bottom of this page, I want you to write nephrotic syndrome. We only have a couple of notes. Nephrotic syndrome. This is more chronic. It's very much like glomerulonephritis. That's why I want you to write on this page. It's just like it, but it's more chronic. With nephrotic syndrome, the difference between the two is that nephrotic syndrome did not have a strep history. There was no strep throat in the history. What there was a patient who probably has an autoimmune response. Autoimmune. This patient will literally waste protein, and a ton of it. Their albumin will be very low in the blood. Instead of the renal diet the way it is, they need high protein diet. High protein. Remember, renal diet is low protein. Who else needs high protein, y'all? Dialysis. Before dialysis, low protein. With dialysis, high protein. So you get two people need a high protein diet, nephrotic syndrome, and you got this dialysis patient that needs a high protein diet. Dialysis, high protein. Without dialysis, if you just got kidney failure, low protein. The patient with nephrotic syndrome has a high cholesterol. The treatment will be steroids. Okay. Turn the page. You should have a picture like this that says fun, okay? At the top, highlight prostate and put this. Benign prostatic hyperplasia. Benign prostatic hyperplasia. BPH, right, y'all? Now, look. The prostate is confusing to most nursing students, unless you know the anatomy of the male. So if you laugh, I will shoot you in your forehead. So we have to know the anatomy of the male. So you are going to be treated with my delightful artwork. Shut up. Shut up. I hear your ass. Oh, shit. Now, sure. Dangling balls. Urethra, prostate. Mirrors the anatomy on the outside. Anatomy on the inside looks suspiciously like the anatomy on the outside. That's how I want you to remember it for this test. Because you have a full bladder, full of urine, you're going to get a reflex. It's going to let the urine out through the urethra, and you're going to pee. That's what should have happened. But your patient is not this man. Your patient has this. His prostate is enlarged. Now, what we have to remember is that If you look at every 85-year-old male in America, they all have BPH. So as you age, it's quite frankly a little normal to have a little BPH. My husband is crazy, you know that. So I find, coming downstairs one day, they're in the kitchen eating breakfast, laughing hysterically about a conversation that made me cringe. The boys, remember I'm not used to boys, married him, I got 3 now. He got 3 boys, I got 2 girls, I'm a girly girl, and they're definitely boy. So they're talking about the day they had a pissing contest. Dad, you remember we were hanging out on the deck and we were trying to piss on the tree? Remember you lost. Think it through. They're teenagers. Their stream was very forceful. It hit the tree. Poor Charlie, he's older. We're old as shit. We're 50-ish. So when he went to go pee, just kind of peed. It didn't hit up on the tree. Wasn't gonna happen like that, okay? When Charlie gets 80, it'll probably dribble. Okay? I don't know, you know? So what we're doing is we're getting a prostate that's getting bigger each year we get older. And what is it doing? It's occluding the urethra. It's pressing on the urethra, narrowing the opening. So when this guy gets such a large prostate that it's no longer acceptable, and that's rare, right? You do get a few guys like that at their earlier years. Most of them are much older, right? You're gonna get these patients all the time, by the way. But when we get a younger guy, you know, he's in his 60s, he's talking about he's dribbling. Don't forget that word, dribbling, it's on your sheet. He's dribbling. It's like I get up at night, I get up at night more than usual. I gotta strain to get the urine going. I gotta really work at it to keep it going. That's all BPH. So when you have that guy, all of this urine does not necessarily come out. Doesn't that make sense? So what does he get? Urinary retention. He gets urinary retention. Okay? So bottom line, as we age, it's normal to get BPH. But some men will get it sooner, and it's much worse than others, at which point we need to do something. Now, there are herbs that actually work. Because you know me, I'm all about think outside the box. You're straight American, you're going to be on some drugs. You need to think about what other people in other countries are doing. Saw palmetto works. You better know it. Saw palmetto works. It's on your medication packet, you know, the one you never look at, where the herbs are, you know that one. Okay, now risk factors for BPH, same shit, different day. Hypertension, obesity, typical American diet, you know how that is. Diabetes, atherosclerosis. So basically coronary artery disease, right? It is more common in African American men. 50% of everybody 60 years old and older will have a little bit. Half of men 60 years old and older will have a little bit. Now, so we're going to try some natural things first. We call that basic care and comfort. We want this brother here not to be doing caffeine, because it's a bladder irritant. All this nonsense makes no sense. So we don't really want him doing caffeine. We don't want him drinking too late at night, because it's going to be getting up all night. It's going to affect his sleep pattern. So we try to say cut it off around 8 o'clock, decrease your fluid intake at night. You got to retrain your bladder. We do this with our elderly patients. we have them go void every 2 to 4 hours. If they're young, probably more like 3 to 4. If they're older, every 2 hours. Bladder training, retrain your bladder. You gotta get it to work, okay? Double void, what does that mean?
They go once and then they gotta go again.
Go once and they need to purposely go again. Because it's still there. Here's a novel idea. Take your ass to the gym and lose some weight and exercise. What does exercising do? You said it earlier. What does it do to the vessels? Vasodilate. More blood flow to the organs, make the organs work better. Losing the weight makes perfectly good sense because when you are a heavy person, you put more pressure on the urethra. Doesn't work so well. Causes you to have these symptoms. And I do want you to know we are dribbling. Okay? So you see the picture. He's dribbling. You gotta know that word, dribbling. It's none of that ball. It's pee-pee. Now, what will happen with this patient as they get older and it gets worse? Look at the bottom. They can get increased UTIs. Infection, you see that? Okay? Now I'm gonna use this page for prostate cancer too. So BPH, boom, we're done with that. Let's do prostate cancer, shall we? With prostate cancer, go to the word hematuria and put painless. Oh, I should look that up. Put painless hematuria. If a man is peeing and it's pink or red and it does not hurt, that is a red flag for either prostate or bladder cancer or kidney cancer. Painless hematuria. What I'll teach you about cancer, most of it's painless. Painless hematuria is a really, really big deal. Now, we screen and we can diagnose. If we're screening a gentleman for cancer of the prostate, when should we start? What age? 40? 50? 50 for Caucasian, 40 for African American. Know your culture. 50 years old every year for the Caucasian male, 40 for the African American male. Now, so when we screen, how do we do it? What is a screening for prostate cancer, everybody? You said what?
PSA.
Is she right? PSA? Raise your hand, don't be a punk. One person thinks she's right. Shut the fuck up. We're gonna try this shit again. Raise your hand if you think PSA makes sense. Shit. Okay. Raise your hand if you don't agree. Anybody out there? Raise your hand if you're a punk and you're gonna make me waste my time and do this again. Lots of you were punks. You didn't raise your hand. We're gonna try this shit one more damn time. Raise your hand if you agree PSA is the way we screen. Okay? Raise your hand if you disagree. Latoya, how you feel about it?
I disagree.
Then why the fuck ain't you raise your hand? Shut up, shut up. We're gonna try this shit again. Raise your hand. You wasting my damn time. Raise your hand if you think a PSA is the way to do this. Oh, okay. Now, raise your hand if you disagree. Damn it. Okay, she's right. What do you think is the way to do it?
In the shower.
No. Here. But I ain't mad. My baby disagreed. She was a little older out there. Digital rectal exam. Why do I make you raise your hand 3 times? Because it must be on a test somewhere in the universe. You have to know this. Digital rectal exam. Now, honestly, your man on some bullshit, like my man. He is not willing to volunteer for you to go up in his ass. Got a lot of men out here ain't trying to hear this, are they? That's the problem. Because let me tell you this. Because see, wives, we got it going on. We got power. We sitting on gold, man. We can make our men go. I don't know what you're doing with the shacking up and shit. I'm talking about married women now. So here we go. Your man on some bullshit, don't want to go for a physical. You a nurse, make buku bucks, and got health insurance, so he ain't got no excuse. But he on some bullshit. Y'all feeling me? Unfortunately, if he would just go, we could prevent almost all prostate cancers. There would be no death from prostate cancer if he would just go. So, what we gonna do? We have to remember with this precious man that we can teach him, and if it don't work, we got powers in other areas. Now, I told man, you better go. I bet you better go. I ain't want to hear this. I ain't even trying to hear this noise. You gonna get that colonoscopy and you gonna get this damn shit you're supposed to have every year. Now, why y'all, why? Because if we catch it early, the treatment is so easy and their life is so full. It is so easy to treat this shit. All the little horror stories they heard are wrong. That was from 40 years ago. There are way better ways to do this now. They just have to go. If they go, we can catch this shit real early. Now, my dad went early. Needless to say, I'm a bit empowering. So he went early. He is 78. He has survived prostate cancer already 40 years because he went early. Why should the African American male go earlier? Because he has higher rates of prostate cancer. He just does. His testosterone is higher. This is based on a high testosterone level. Why is a digital rectal exam better than a PSA? Because I can literally feel cancer with no problem when I do this exam. I can feel it. It's so easy to feel, but you never got it done. Your doctor is even on some bullshit. You found the courage to go, and the doctor didn't even do it, and you not gonna ask because you don't want to look like you want his hand up your ass. No kind of way. You feeling me on this? You got doctors that will not ask. I can feel this cancer. It is so easy to feel. It feels like a very hard brick or rock in your body. It's so easy to diagnose with your fingers. It's so easy. Now, if I feel what I feel, then you can have a PSA. So together, they make a perfect pair. But if you gotta choose one, you know, like on a test, this is more. Because I can feel this cancer, so easy to feel. Breast cancer is actually harder to feel than this. This is easy to feel. There is nothing like it in your body that should be there. This is easy to feel. Okay? It's not about enlarged. It's the feeling of cancer. Hard, brick-like, pebble, hard rock. That's what we feel. Okay, so I want my babies to know that our men gotta go. And if you have a daddy, you're gonna have a conversation with your daddy. Okay? All right now, so that is your prostate cancer. Turn the page. What do you got? Medications or something? Is that what it says? Yes. Just put on your PSA because I want to put some cancers on here. Just make sure you know this PSA depends on the man's age. We used to say this. We used to say this. 0 to 4 within normal limits. But if you are 35, 4 is not normal. But if you are 72, 4 is normal. So this is what we say now. Let's look, because I love the bubbles on here. The bubbles actually help you a lot. It says the PSA range for healthy prostate is 0 to 2.5. What's your PSA range? And then they go over here and say something a little different. They say something a little different. They say with my BPH, what does that stand for again? B9. What is B9? Non-cancerous. So with my BPH, they gave me a 4 to 10 range, which was normal for that patient. Are you feeling me yet? That's why we can't do this no more. We can't do that no more, because we got normals for different people. And they said Sam's was over what?
20.
Now, I don't care what your problem is, 20 is bad. Do you see where I'm going with this? My father was 11. He went early, but he was young, 40 years old, with 11. That's crazy. If he was 80 with 11 and had BPH, that might be okay. So he got diagnosed early, okay? Do you feel me on that? 11 at 40 is not the same thing as 11 at 80. That's why you gotta know the age of the patient. So PSA, you have to know the age of the patient, okay? Now, the patient with the benign prostatic hypertrophy will have a higher PSH, that's what that's telling you. That patient who is young, that has a high PSA, an abnormal digital rectal exam first, right? We did that first, and has this, okay? This patient needs a biopsy, because the only way to diagnose is a biopsy, and you know this. You know that, that's cancer talk, right? The only way to diagnose cancer is a biopsy, okay? Now, my dad got some radioactive seeds and was good to go. They monitored him, it came back, I don't know, 20 years ago, but it was a low grade, so they just said, oh, you don't need any treatment, and he didn't. 20 years later, he's still doing great with that same number, it's low grade, okay? What you need to be aware is as long as we know, we can treat what we need to treat and leave things alone if they don't need to be treated. We didn't know that 50 years ago. We had no idea that some prostate cancers are better left untreated. We had no idea. Some are aggressive. They will kill you within 2 years. How do we know? We don't without a biopsy. Raise your hand if you lost a loved one to prostate cancer. It's not uncommon. You've got these hands up. How old were they?
My first father was like 86.
How old were they?
My grandpa was 76.
Okay, it is very common. Yes, baby.
My grandfather-in-law was in his 50s.
Yeah, didn't need to happen. I can almost promise you the screening probably didn't take place at 40. No one needs to die from this. You know what I compare this to? Cervical cancer. No one needs to die from cervical cancer. We do PAPs. We go every year or every 3 now, but these guys don't go every year, and it is every year. It is every year. Gotta know that. All right. Okay, turn the page. Now, on this page for these different medications for BPH, I need you to make sure you know that the category is called alpha, put it at the top, alpha adrenergic blockers. Alpha adrenergic blockers is what it's called. Now, alpha adrenergic blockers sound a lot like beta blockers, don't they? You know why you care? Because you want to remember if it says blocker anything, it's going to lower blood pressure. Beta blockers, calcium channel blockers, adrenergic, alpha adrenergic blockers. Blocker anything is going to lower blood pressure. That's what you want to remember. It's a good way to remember. Why do you give a shit? Because he's taking it for something else. He's taking it for his prostate. But while he's taking it, his blood pressure is going to go down. If he doesn't have high blood pressure, that might be a problem. So he doesn't need to take any other things that might lower his blood pressure as well. What do I mean? I mean, he better not be on no damn ding-a-ling drugs. Name a ding-a-ling drug. Viagra. What does the action of Levitra, Cialis, and Viagra do? What is their action? They do what? Vasodilating. They're gonna die. You know what I say, they're gonna be coming and going at the same time. In other words, he done got his blue diamond going, his Viagra. He done bought it for about $10 on the street over there on Cedar. Got somebody at the VA to hook him up. That's how they do, y'all. I'm telling you what they do. So you done got this little $10 hookup, you got your girl. You already on this for your prostate, so you can pee. You're dead. You are literally dead within about half hour. That's what you better know. Because these drugs cause low blood pressure. Okay? That would be wonderful if your ass got high blood pressure. We can knock out your prostate problem and your low blood pressure. Give you the double whammy. Okay? Now look at the handout. The handout says Proscar, and then it says Avodart. The problem with the Avodart, y'all see that? Is they put the wrong drug on top of it. That is not the same name. Avodart is dutasteride. So cross out, don't cross it out, but yeah, you might as well cross it out and write it somewhere else. I want you to write that tamsulosin somewhere else, because it's all messed up. That's why I better read what I give y'all, because I got to check it, right? It's messed up. So where it says Avodart, cross out your tamsulosin and make sure you write dutasteride. Okay? Now you still need tamsulosin up there. So write that somewhere on that sheet, tamsulosin, and put Flomax, because that's what that is. You can put your Flomax. So Flomax, Proscar, Avodart are brand names. Tamsulosin, finasteride, and dutasteride are generics. What do you have to know? Same thing with the blood pressure medicine. Rise slowly. You might get dizzy. You could faint. So far, so good? Yes, no, maybe?
Yes.
Okay. Now, these drugs often end, not totally, but a lot of them will end in osins. Tamsulosin is an example. I'm going to give you some more osin drugs because they're important. Prazosin, Terazosin, Doxazosin. Now, here's how cool this is. If we look at the brand name for these drugs, Prazosin is actually mini press. Mini press. Minimize your blood pressure. Mini press. You can remember that. That's the brand name for Prazosin. Terazosin is Hytrin. Hytrin. Hytrin for hypertension. Hytrin. Doxazosin is Cardura. Cardiac friendly because it lowers your blood pressure. Cardura. Extending the duration of your heart, cardiac duration, Cardura. They're named after their blood pressure effects, not their prostate effects. But you got to remember their zosins or osins. It's a good way to remember it. Okay, that's your medications. Okay, turn the page. TURP. Now, TURP is your transurethral resection of the prostate. This transurethral resection of the prostate is basically the last resort for BPH. Last resort for BPH. It's not the first, it's the last resort. It is RN only patient. RN only. Now look at the drip. You gotta know this drip. This drip is called a Murphy's drip or continuous bladder irrigation. So it's actually called a Murphy's drip. If you look at it, it says continuous or intermittent what? Bladder irrigation underneath the CBI. Do you see the Murphy drip? Okay, now, let's look at the picture. That's why I like these handouts. The picture speaks 1,000 words. Do you see it says sterile antibacterial isotonic irrigation solution? Oh, okay. So it's dripping and it's going into a catheter, a 3-way catheter. And you have the other port of the catheter draining what? Urine. It's a 3-way catheter. So you're putting fluids in and we're draining urine out, and we got one more port for the balloon. Correct? Now, I'm so mad at myself for getting rid of my beautiful portrait here, because I gotta draw this shit again, damn it. I'm really mad about that. So we're gonna try to do that again. Okay, let's see here. The bladder. And you know I'm a perfectionist, so it's like, oh, get this right or you won't understand it. Okay. Okay. To understand a TURP, we've got to understand how in the hell does it sit inside of this patient, right? Okay. Now, prostate, boom. Prostate, boom. What did we say the problem was? The prostate is encroaching or occluding the urethra. So you had surgery for that. And when the surgeon got inside, he went through your urethra, transurethra, to the prostate. He took his scalpel and he resected a portion that was too large, leaving you a nicely dilated urethra, normal urethra. Then he took a catheter and he inserted it, not you. He did it in the OR. The surgeon inserted this catheter. When they inserted it, they didn't do it like we do it. You and I generally will insert a Foley catheter. When we get a urine return, we will blow up the water balloon and it will sit where? Exactly. That's not what this guy did. That's why UWorld is wrong on this. The picture's wrong, the description's wrong. It's okay. I'll do this. They don't, apparently. Okay, so when we have a catheter on this man, the surgeon has inserted a catheter, but he did not blow the water balloon up in the bladder. No. He blew it up right here to put pressure on the incision area. If this patient bleeds, why would he bleed? Because you took a scalpel to his prostate. If he bleeds, all your surgeon has to do is blow the balloon up bigger to put more pressure on the area. That makes sense. So if you call the physician and say, hey, you know, the gentleman named in room 10, he had a TURP this morning. His urine is getting darker. He's having more clots. I think you need to come see him now. He'll come in and go, oh yeah, you're right. I don't like it. Should be getting clearer and clearer as the evening goes on. I'm gonna go ahead and put more water in the balloon. That's what happens. More pressure to the area. Does that help a little bit? Okay, now, generally speaking, this RN only patient is doing well as the hours go. What are you doing with him? You're making sure he's on strict bed rest. You're making sure he has a clear liquid diet. You don't need him having to go potty and do a Valsalva maneuver trying to poop, because it's going to push that catheter out. So he is on strict bed rest, clear liquids. When he does eat, he will have a high fiber diet. He will have stool softeners, because a Valsalva is crazy. So far, so good? All right. Now, he's going to go home. He's going to have some teaching. His teaching will include continue his stool softeners, continue high fiber diet, continue pushing fluids. Why? Because the last thing he needs is constipation. Kegels. He will need to be taught Kegels because incontinence is common after a TURP. He will leak urine. He needs to be aware of that. He's going to strengthen those muscles back that we had to go through to get through this prostate, and he's going to strengthen those muscles with Kegels, and he's going to do them at least 10 times, 3 reps a day or more. So 3 times a day, he's doing 10 in a row. 3 times a day, he's doing 10 in a row. No lifting. No lifting anything higher than 20 pounds. No sexual intercourse and no Palm Beach. What is Palm Beach? You better say it because you got guys out here doing whatever, so it's okay. You just have to be real with the person. No Palm Beach. Now, so you have to make sure that this man understands there is a possibility when he, after about 4 weeks, and he's allowed to have sex, he may have retrograde ejaculation. That means when he ejaculates, it can end up in the bladder, and when he urinates, it can be cloudy. That's no big deal, but if you don't tell him, he's gonna freak out. So retrograde ejaculate means his urine is cloudy, and it's from the fact that he's not healed completely up, and that's okay, that happens. It can be pretty common, and it will get better. No coffee, no alcohol, no caffeine. Okie dokie, that's that. TURP, big deal, TURP. Testicular torsion. This is really simple. Use the same page, it's about 2 lines and you're done. Testicular torsion is a medical emergency. It happens in a young man. That's why I told you when you analyze each question, look at the age of the patient. The patient will be under 25 years old. They can be as young as 2 or even whatever, but they're younger than 25. If it's a young man with severe groin pain, assume testicular torsion, call 911 or check, well, you gotta assess, of course, if you're able to assess. If you're not, and it's a phone call, come right in. Okay, severe groin pain that happened all of a sudden in a young man is testicular torsion. Now, you have to know your anatomy. You're not gonna see no twisted scrotal sac, stop tripping. It's inside, it's not on the outside. His testicle is twisted. Torsion means twisted. It is threatening to fertility. It needs to be addressed yesterday, emergently. If you address it right away, you can usually, the physician can usually manually turn it back under very good pain medicine. If you don't address it right away, it's surgery to try to repair it. It can cut off fertility, you know that, okay? It's a testicle, come on, okay? Now, what will you see? Because you should be assessing. So you're the school nurse, and one of the things that I find comical is when I go around the room and say, you got a 15-year-old, severe groin pain, they come in, they're doubled over, they're crying, they're upset, they're moaning, and what should you do? You say call 911. No, you should assess his scrotal sac. I mean, you should assess him. But somehow you think that you're a child molester because he's 15. I need you to know you're a nurse. A nurse has to assess. This gentleman has to come in the privacy of an exam room, and you have to tell him to let me see what's going on, sweetheart. You're gonna have to remove your pants, and let me just check. and you will see very clearly what's going on. There will be swelling and blue. So now you can call 911. You'd be surprised when I go around the room the craziness I hear. I ask you, what's your first nurse action? I've had you tell me call the parents. What the fuck are the parents gonna do? I've heard you say dial 911, call the doctor, have them put some ice on it. Oh, okay. Now, no, you assess if it looks swollen or blue unilaterally. You can call 911. While you're waiting, elevate an ice and call the parents. But ain't shit a parent can do. This baby is needing care yesterday. Okay, so you can call them after you take good care of your patient. By that point, they probably should just go to the hospital because he's gonna be gone. You don't want them at the school screaming. Okay, so know the way we do this. By the way, in case you think this is a bunch of bullshit, Teresa Mancharo, she left here from my class. She had failed 3 times. She went to Florida to work, and I think it's at the Cleveland Clinic down in Florida. She texts me, she has a 15-year-old son who all of a sudden came in, had been hit by a football. She said, all I could think of was how crazy you were in class. You told us our first nursing action was drop your drawers. First she knew it, she told her 15-year-old son, drop your drawers. Mom, drop your drawers! He had testicular torsion. She saved her son's fertility, okay? All right, so there you go. Now, turn to UTI real quick. It's easy. Everybody in this room knows what a UTI is. It's simple. I have a few more things on this and we're done. Look at her. She look a hot ass mess. She's not happy. Her knees and things is crossed. You have to know the triad. For UTI, there are 3 things that every single UTI will have. What are they? Frequency, urgency. What is pain, nurse? What is that, nurse? Dysuria. You better know your triad. Frequency. Gotta go all day, every minute. Gotta go a lot. Urgency, gotta go right now, but I just went and that's weird. Dysuria, pain. Easy, this is easy, okay? Now, look at her. Look at her crazy behind. If you look over at the left-hand side, it says cystitis. You with me? So you should have highlighted frequency, urgency, and dysuria. Now, you ought to take that confusion in older adults and highlight it a different color, because that's going to be first for older adults over 65. You 23, your ass should not be confused with a UTI. But the elderly are. Fever is rare. Put rare. Cloudy urine might be going on. Cloudy urine might be going on. Because what we say, come out the body cloudy, it's infected. Now, here's what a lot of y'all do. You are busy individuals, you're nurses, you can't miss school, you can't miss work, you can't do any of that. So what do? You do the self-treatment crap. You go to the nearest drugstore, going up here to Rite Aid, CVS, whatever. You go buy some old crap to make the pain go away, Urostat or whatever. You decide today, I'm not drinking no pop, and you go find some cranberry juice and a whole bunch of water, because you don't have a $35 copay for Shelly. And so you go and try to treat yourself. Now that works for about a day or so. What's happening while you try to treat yourself? The bacteria is getting worse. What is it gonna do if you never go for a lot of what you're doing here? If it's a true thorough infection, it's going to what? Ascend up to the what? Kidneys. Do not confuse your language. Patients are confused. You can't afford to be confused. You're a nurse. Don't say in the same breath, kidney infection, bladder infection. They're not the same thing. Kidney infection is major. It's called pyelonephritis. Urinary tract infection called a bladder infection is not that serious. But pyelonephritis is very serious. The bladder infection can lead to pyelonephritis. Both are considered urinary tract infections. So far, so good? There is a difference. So if you look at your handout, and you see this lady got a UTI, she will not get a pyelonephritis if we treat it promptly. What is causing her infection? What bug? E. coli. You better know it. E. coli is causing the infection. Where did she get that from? Her colon, right? It's normal. Your colon has E. coli. It better. But your colon should not have the E. coli that's supposed to be there. It should not get into the urinary system. So that's where you have your problem. E. coli is normal in your body, but not in your urethra or your bladder or your kidneys. Okay? All right, so if you look at it, you see pyelonephritis. How does it differ? Please use this word. Pyelonephritis is systemic. UTI is local. If I have a UTI, it's local. I'm not going to have a fever. I'm not going to be vomiting. I'm not going to be tachycardic. I'm not going to be feeling like malaise and all this crap, because it's local. It's only in my bladder. That's all it is. In the bladder, that's it. It's nowhere else. But once I get to pyelonephritis, it's now systemic. It has the potential of being septic. It has the potential of making me septic. That's why you gotta know. Pyelonephritis can lead to urosepsis. That's deadly. So I don't admit UTIs, that would be dumb. But when I get a patient with pyelonephritis, I admit her to the hospital, and she's gonna get some IV antibiotics. When you have a bladder infection, you're gonna get some Bactrim or nitrofurantoin. And what are you not gonna get for a simple UTI, everyone? Cipro. Hell no. Cipro has a black box warning. You're not gonna get that for a simple UTI, because Cipro can give you a prolonged QT interval, and it can also give you C. diff. We're not doing Cipro for a simple UTI like so many doctors and nurse practitioners currently do. But you're smarter. I just had a young lady in my class. She had fibroid surgery. Her name was Katie. She told the whole class. She said, look, the first thing out of her mouth, because I had got complications afterwards, was you have a UTI, I'm going to give you Cipro. First thing out of Katie's mouth was, no, I don't want that. Can you give me something else? Oh, well, okay, no problem. I'll give you Macrobid. Thank you. It's that simple. A lot of doctors prescribing this drug, and it's not a good drug unless you need it. And you don't need it for a simple UTI. Okay? All right, so we have this patient, chills, fever, vomiting, tachycardia, whatever. That's going to be pyelonephritis. That's not a normal bladder infection. That patient needs to be admitted. Go over there to the right-hand side. At the bottom of the page, it says may require hospitalization. I don't do may. I literally will hospitalize you. Ain't no maybe with me. At the very least, I'm going to put you in the ER, run some IV antibiotics, even if I just keep you for observation, and you're gone before 24 hours has passed. I'm not doing this at your house. I take it too seriously. Okay? If you look, it says IV antibiotics. It says you may go into septic shock. This is why I'm not trying to do this at your house. That's not me. That's not how I operate. Now, when we're trying to look at this patient, I want you to go up to the diagnosis. I want you to highlight nitrates. Remember, this patient needs a urinalysis and a CNS. It's already written there. Highlight it. We need to push fluids. Sounds cute. If we push fluids, how many liters? 3,000. Not 3,000 liters, that doesn't make sense. 3 liters, 3,000 cc's. Okay? Now, I do not have to go over prevention with you. It's written there, it's common sense. However, let me say what may not be common sense. If you rocking dental floss for your underwear, you know, thongs, So you keep getting a UTI, it's because you got that dental floss on. Because every step you take E. coli and put it in your urethra. The E. coli came from the rectal area, you walking and moving a string back and forth. Better get you some sexy ass boy shorts, leave them damn dental string alone. Okay, now, if you turn the page, you've got some more wonderful prevention tips. Okay. All right, then you turn the page again, you got a medication. This is called pyridium. What color does it turn your orange? Your urine. It turns your urine orange, right? Highlight it. It will stain clothes, contact lenses. It says it right on there. Pyridium is going to be phenylzipyridine on your test. Urinary analgesic. I want you to write those words. Urinary analgesic. Now, I want you to use this page and write down, what is it? Stress incontinence. Write that down. Stress incontinence. Urge incontinence or stress incontinence, doesn't matter. The patient needs to keep a bladder log, a bladder diary, avoid caffeine, pop, coffee. Avoid caffeine, pop, and coffee. Keep a bladder diary, and make sure she goes every 2 hours. I can treat urge incontinence. It's difficult to treat stress incontinence. Urge incontinence is you standing here like I am right now, and you just start peeing because your bladder's full. No warning, just water in your shoes. Stress incontinence gives you a very clear trigger. Either you were jumping up and down, you were laughing really hard, you were carrying something, you lifted somebody, you were singing in choir, you cough, you sneeze, boom, stress. Know the difference. Now, this last part on this thing, getting some cancers already, that's cool. This last little part on this sheet here, testicular cancer, I want you to notice some of these words. I had up here, prick, I have cryptorchidism on here. If you turn, let's see what we got. I want you to turn to renal calculi. It should be in here somewhere. Oh, you know what? No, turn to erectile dysfunction drugs. This is hilarious. Okay, last page, I believe. Last page, erectile dysfunction, dingling problems, okay? Now, here's what I want you to do. At the top, you're just gonna put exactly what I put here. You're gonna put the word cryptorchidism. And I want you to know the little word here is orchi. Orchi means testicles. Cryptorchidism, testicles, if I send you a cryptic message, what does it mean? Hidden. The testicles are hiding. This is undescended testicles in a newborn baby. You still with me? Undescended testicles in a newborn baby should not happen if you're full term. What's full term maternity patients? 37 or what?
42.
42. That's full term. If you have a child full term with undescended testicles, that child should be monitored for testicular cancer. That's what you better know. Yes, baby.
How long do they have to be monitored? My son had that, and he's had surgery 5 times already.
All their life until they reach about 35 and the risk is gone because testicular cancer is a young man's condition. It's under 35. I pray that your pediatrician shared that with you. Okay, good. Okay, so cryptorchidism, failure of the balls to fall, right, as a newborn, because they should drop. As you go through your growth in mommy, a fetus grows in mommy, the testicles are in the pubic area. They need to drop into the scrotal sac. They did not do that. They're called cryptorchidism. This child is at risk for testicular cancer. If they were to have cancer, it's usually unilateral, but once you have it, you're at risk for the other testicle. So unilateral, hard as a rock, right? Hard. I told you I can feel cancer. Hard, like a rock. It's a nodule or a rock-like feeling on the testicle. Then we would have to do what? What does that mean? That's why you gotta know your words. Removal of the testicle. So all these three go together. That's all you had to know by that. But you had to remember it was a young man's cancer. What should you do, nurses and mothers and daddies? You should be teaching testicular self-exam starting at 12 every month in the shower. So, you know, I got these boys now, right? 8 years of boys, teenagers, they're grown now. But I'm just saying, when I got them, they were young. So I go home, I'm saying, well, what the fuck? I done taught this shit at work. I might as well go home and make sure this foolish husband of mine is doing what he's supposed to do. I go home, I say, hey, Charlie, do you talk to the boys about doing their testicular self-exams? Oh, I don't know. I don't know if I remember that. Let me go and tell this fool now. He walked by the youngest one's room. He was 15 at the time. He's grown now. Hey! Why you jacking off? Check your balls for cancer. I cannot do boys. I don't know nothing about boys. I couldn't believe he said that. I was like, oh! I cannot. Okay, one more cancer you gotta know is a one-liner. I swear to God, it's a one-liner. I had it up here, I'm gonna put it a little higher. Wilms tumor, and we're about done. We got that little kidney stones, but we're about done. Wilms tumor is a cancer of the kidney. It's gonna be called nephroblastoma, tumor of the kidney. 2 to 7-year-olds get it, usually a toddler. You remember learning about it. What did you have to teach?
No palpation.
No palpation. So you put a sign up at the bed in the hospital, no palpation. What are they gonna tell you? I mean, what are you gonna be worried about? Nursing assistants tickling the kids and the rainbow babies and children in the hospital, right? When you're tickling kids, you know, you tickle their belly. You can't do that with this kid. You can't touch their belly at all. Because if you do, what will happen? It will spread the cancer all over their body. No palpation of the tummy, no tickling this baby, nothing. Usually a toddler. Now, the precursor was this, that's why it was on the board, hypospadias. Hypospadias, it means the implantation of where they pee, the urethra. The implantation of the urethra was not in the center of the penis, it was up under. Hypo, too low. It was too low. If you have an epispadias, the implantation of the urethra in this newborn baby's penis is on the top. If I have an epispadias, when I pee, it's gonna go straight to the wall. If I have a hypospadias, when I'm 2 years old and I pee, it's gonna go on my toes. You won't be able to hit the Cheerio in the toilet, right? That's what you train the 2-year-old baby boys with, Bryce, right? So you won't be able to hit the little Fruit Loops, right? Because the urine stream will be in another area, okay? The reason why you give a shit is because if a baby is born with anything, hypospadias, epispadias, they cannot have a circumcision. You have to save the foreskin to repair the defect later. No circumcisions on hypospadias or epispadias. You have to save the foreskin to repair the penis later. Now, hypospadias patients are at risk for Wilms tumor. Last one, and then we have a break of it, all of 5 minutes. I do. You do you. Okay, now, so renal calculi, turn to that, go backwards and find your little renal calculi lady or man or whatever. Now, renal calculi is usually seen in men, but women can get kidney stones any day of the week. So just know, it's mostly men, but women can get them. If women get kidney stones, it's usually in pregnancy. So again, kidney stones are usually a male thing, but women can get them as well. And when my females have gotten them, and I have had patients with them, they were pregnant. Now, here we go. This person is in so much pain, we say it's like labor and birth for a man. It is their version of having a baby. Think about it. Big ass stone coming out a little bitty pee hole. That's what delivery is. For a woman, it's different. At least we have a head that's round. The stone is jagged edged and sharp. It will tear everything in its path. That's why he's on the floor, writhing back and forth. Who's at risk? Husky guys, big, obese guys who don't move. Who is that? Your truck drivers. UPS, not UPS really because they move. Your postal workers, your truck drivers, people who drive all day, big guys who don't exercise. They don't do nothing but eat meat and potatoes. They don't get a vegetable. Their idea of hydration is a 6-pack. Alcohol. Because what do you know about alcohol? It's dehydrating. If they do drink, they have to have iced tea. Iced tea can lead to this as well. So again, big guys, no movement, dehydrated, alcohol, iced tea adds up to kidney stones. Now, they're going to look a lot like your pyelonephritis patient. Sometimes you can't tell the difference. They're going to have every single symptom that pyelonephritis has, okay? They need to strain all of their urines because we want to analyze the stone. So we have a hat, you know what a hat is. We have a hat to strain and capture all of their urine. And we're going to take each sample that they put in this hat and we're going to strain it to get the stones out of it, okay? So you cannot let them waste their urine. They can't flush it, they got to save it, okay? So we're going to strain all their urine. The key is a rhyme. So if you think about this guy and all the things I told you caused it, it's a rhyme. Hydrate, medicate, ambulate. That's the treatment. Hydrate, medicate, ambulate. Medicate for the pain. Hydrate, medicate, ambulate. Get that stone to move down and out. Flush it out. Walk it out, flush it out. If that does not work, we go to bigger guns. Lithotripsy. Lithotripsy is where we take a laser and we take your stones and blast the shit out of them and make them into sand. We destroy them into little teeny tiny bits like sand. You still need to strain all your urine. This is not surgery. This is laser. We're just gonna blast them. You're gonna have bruising on your belly and your back. You will have hematuria. Sometimes they give you a general anesthetic, but it's not surgery. It is not surgery. It's generally outpatient basis. They cannot be on Coumadin or any other kind of medication that will make them bleed. Diagnosis, helical, CT, which is a spiral CAT scan. Helical or spiral CT. That's how we diagnose this. Do I have to have that? Nope. I could use an ultrasound, intravenous pyelogram. Remember, with an intravenous pyelogram, it's gonna be contrast dye. You need an IV, and they need a bowel prep beforehand. IVP. IV, contrast dye, bowel prep. We're done.